Lee, the floor is yours.
Good morning, good afternoon, and good evening. My name is Lee Hall, and it's my pleasure to welcome you to this third webinar sponsored by the Global Vaccine and Immunization Research Forum, or as it is more popularly known, the GVIRF. I'm from the National Institute of Allergy and Infectious Diseases, part of the National Institutes of Health in the United States. Together with the World Health Organization, the Bill and Melinda Gates Foundation, the NIAID is one of the organizations hosting the GVIRF. The GVIRF is the central forum for research and innovation related to Immunization Agenda 2030 and typically meets every other year. It is the only global meeting that regularly brings together the entire vaccine and immunization research community, from basic immunology to implementation research and from low to high income countries. And it provides opportunities to, one, track progress in research and innovations related to vaccine discovery, development, and delivery. Two, identify gaps, opportunities, and actions to maximize the benefits of immunization. And three, foster networking and collaboration to accelerate progress. After our last GVIRF meeting, we realized that a lot happens between the biennial meetings and that we can share information very effectively through virtual conferences. As a result, we began a series of webinars to be held between GVIRF conferences. Our first one dealt with an emerging technology, mRNA vaccines, and our second one dealt with vaccines to prevent a global scourge, malaria. This third webinar, organized principally by our WHO colleagues with input from partners at the Gates Foundation and NIAID, deals with vaccines to combat another global threat, namely antimicrobial resistance. This is a timely and important topic for a couple of reasons. There can be no doubt that the discovery and use of antibiotics in the last century dramatically reduced the mortality and morbidity caused by infectious diseases. Over time, however, viruses, bacteria, fungi, and parasites have unfortunately evolved mechanisms to render antibiotics less effective, thereby significantly and adversely impacting our ability to treat these infections. To our dismay and alarm, such organisms have also demonstrated an ability to spread rapidly and globally. Vaccines, which harness the ability of the immune system to target such organisms, present an attractive alternative to combat these organisms and to reduce their spread. We thank you for joining what promises to be an exciting webinar. And at this point, I'll turn the virtual podium over to Alex to explain the technical setup for today's webinar. Thank you all for coming. Alex, it's yours.
Thank you very much, Lee. Let me just share my screen for the presentation. Right, can you see? So thank you very much, Lee, and good morning, good afternoon, good evening, wherever you are. My name is Alexandre Pascotto. I'm the TechNet 21 Community of Practice Manager, and we are providing the technical support for this webinar session. I hope you'll enjoy the content and experience. Just a brief description, and for those who don't know TechNet 21, TechNet is a network of immunization professionals and a platform managed by the World Health Organization. Our mission is to improve immunization services by bringing together immunization professionals at every level, in every country, and from every sector. To do so, we use various digital tools to allow immunization professionals to keep learning and collaborating and to improve their network. We provide a technical, organizational, and communication support to online events, and we also hold a large international conference on immunization supply chain every 2 years. If you have any question regarding the platform or looking for support to hold any online events, you can contact me by replying to the Zoom invitation you received to connect to this session. During this session, if you have any technical issue, please contact me via email, or you can contact me also directly on the private message in the chat. This webinar is recorded, and we will send the links to the recording as well as the presentation by email to everyone who registered. Finally, there's a possibility to listen to this webinar in English and in French. To do so, please use the interpretation icon that you will see at the bottom of your Zoom screen. That's it for me. I'll give the floor to Bill to go through the agenda. Bill.
Thank you very much, Alex. Can you put your slide on presentation mode?
Isn't it?
It doesn't seem to be.
Sorry, excuse me. I thought it was.
Yeah.
Give me a second. This is supposed to be in presentation mode, so I'm going to stop sharing.
Meanwhile, I'll tell stories. Now, I want to say good morning, good afternoon, good evening to everybody while Alex is working on this. My name is Bill Hausdorff, William Hausdorff. William is Bill, for those who are not English speakers. Bill Gates is William Gates. Bill Clinton was William Clinton, and I'm Bill Hausdorff. And I'm delighted to be here. I'm delighted to be invited. I work for PATH, which, as many of you know, is an international health NGO. I'm based in Washington, D.C., and I want to thank the World Health Organization, NIH, and BMGF people for organizing this and for inviting me to chair it. So the topic for today, as you know, is the role of vaccines and AMR. And I have learned, the more that I have been delving into, I've worked with vaccines for many years, and only in the last few years really focusing on AMR, how much of the time we are talking to ourselves in the vaccine world. There's an AMR world looking at a number of other interventions, which are very important. And then there's a vaccine world. And I think it's not always clear, I know it's not always clear to many people that vaccines, what the role is or could be of vaccines in preventing antimicrobial resistance. So hopefully this particular webinar will help address that, but it's an ongoing struggle because we live in different camps. And I think vaccines clearly have a major role to play, but they're not the magic bullet. The agenda that you see in front of you is organized in 2 sessions. We'll have Professor named Sally Davies giving an opening talk on her perspectives on the importance of AMR and vaccines and their role. The first session is really about the problem of AMR and how vaccines can and could help prevent it. And you see the distinguished speakers we have, followed by a panel discussion at the end. The second session, if you could flip to the next slide, please, Alex, is about how do you translate this into policy? You've got vaccines, that's very nice in theory. What actually happens, and how often is this actually a reason for vaccines to be used or to be developed? And so we have a couple of really interesting presentations about that, including a very interesting case example from Zimbabwe, and then followed by a panel discussion. Throughout the agenda, although most of the actual presentations are recorded, we do want Q&As, and the speakers are standing by waiting for your questions. So please feel free in the Q&A to put in your questions as speakers are talking, and we're going to, at the end of each of the presentations, try to take 1 or 2 questions for the speakers, and then of course the panel discussion will give us more time. So I think that's all I wanted to say. I wanted to now turn it over to Dame Sally Davies to give her perspectives on AMR and how vaccines, oh, sorry, you'll see the panel discussion members here, but they'll come back later when we get to their the time point. So Dame Sally, would you please tell us what you think about all of this?
Thank you, Lee. Thank you, Bill. And hello all, nearly 450 people. I'm very appreciative that you've invited me to talk to you at this webinar. And I understand that we've got a real mix of scientists, product developers, regulators, policymakers, implementers, and funders dialing in. So welcome, everyone. I hope what I've got to say matters. Well, it does matter to all of you, that I promise, but that I can help you understand why it matters. And, you know, vaccines are often underplayed in their role to prevent antimicrobial resistance. So yes, this matters. We can all see as we look that even aside from the health impact, the COVID-19 pandemic has affected jobs, poverty, the economy, food supplies and security, justice, equality, and political stability. But I describe COVID-19 as a lobster dropped into boiling water. It makes a lot of noise, suffers, and then dies. Whereas AMR is that lobster in cold water. It's heating up slowly. It's not making any noise, but it's suffering, and given time, it too will die. And so if we don't see it, AMR that is, or hear it right below our vision, then are we taking enough action? In other words, I think, and I think the evidence is accumulating now, that AMR is going to be just as deadly as COVID-19 over a longer time frame if we don't act now. And actually, AMR is already killing swathes of people. We know that as bugs are exposed to antimicrobials over time, mutations help them get better at evading the killing or growth-limiting action of drugs. Life-saving drugs become less and less effective against pathogens until they become useless. And actually already some pathogens like Neisseria gonorrhea have evolved strains that can no longer be treated successfully with licensed antibiotics. Even if we weren't convinced by this humanitarian argument for action against AMR, the financial case is frankly a no-brainer. In 2016, our UK government commissioned Lord Jim O'Neill to write a report about AMR. He's an economist, and he estimated that by the year 2050, AMR could cost the global economy $100 trillion US. At the time, his statement that a health issue could cause such a huge economic damage was not taken seriously enough. But the World Bank has described AMR as an exceptional economic and health investment for countries and projected a high rate of return of 88% per year if 75% of negative effects of AMR could be avoided. In other words, inaction will cost far more than action. And in case there's anyone around who's still not getting the message that AMR is a global health threat, the recent report from the Global Research on Antimicrobial Resistance, GRAM, from the Global Burden of Disease people, published in The Lancet in February this year, provided us with powerful quantitative evidence of the global burden of AMR. They found that an estimated 1.27 million, so that's just under 1.3 million people, died from antibiotic-resistant bacterial infections, so we're not even talking about malaria, TB, and other things, in a single 12-month period to 2019. That's more deaths than HIV or malaria. It makes AMR the 12th leading cause of death globally. Actually, with the 5 million deaths when people died, they did have drug-resistant bacteria in them, causing some problems. It makes it the third most important underlying cause of death after heart disease and stroke. So people need to wake up. And tragically, 1 in 5 of these deaths are among children aged under 5 years. And the data shows, not surprisingly perhaps, inequality and health disparities are crippling characteristics of AMR. Globally, sub-Saharan Africa was the hardest hit by AMR, directly causing 24 deaths per 100,000 of population, which is almost double the 13 deaths per 100,000 in high-income countries. So none of us can be complacent. The data shows we are now much closer to Lord O'Neill's chilling prediction that by 2050, AMR could kill 10 million people a year. Globally, this data also demonstrates data disparities and lack of infrastructure and capacity for surveillance that we need to detect and respond to pandemics, and actually make the case for vaccines too. But the data reflects national and local health determinants to a certain extent. For example, we know that in the US, the biggest determinant of death in severe sepsis is socioeconomic status, with Black patients twice as likely to die as white patients. This data has given AMR visibility and a voice, but what we do with it and how much future generations will pay depends on what we do now. The global scientific community, as we know, was able to develop COVID-19 vaccines rapidly because they built on years of earlier investment and research. We need the same for vaccines that prevent bacterial infections. In fact, the bulk of health and economic burden of antimicrobial resistance probably comes from antibacterial resistance. Unlike in the past, we can no longer count on a successive stream of new antibiotics to overcome the threat, partly because there's limited incentive for big pharma to invest in antibiotics. Because making a new antibiotic, actually like any other innovative therapy, is incredibly expensive. A recent estimate put it at least $1.7 billion US all in to make a new antibiotic for human use. It's hard then to recoup that investment on a low-cost product like antibiotics, especially when use of that product is discouraged through antibiotic stewardship. That term, antibiotic stewardship, simply meaning that it's our responsibility to make sure we hand these invaluable drugs over to future generations in good working order. The easiest way of achieving that is to reduce unnecessary antibiotic use, of course. However, our stewardship efforts mustn't come at the expense of patients who need treatment. So it's the access versus excess debate. Already, many people in low and middle income countries don't have access to the medicines they need. So it's not easy to reduce overall antibiotic use, yet at the same time make sure no one who would benefit from the medicines is denied. This difficult balance is at access versus excess. So let me tell you two sectors where vaccines can help slow development and transmission of AMR. First, vaccines can help us reduce the amount of antibiotics used in food production, the food chain. Immense. You might join me in saying obscene amounts of antibiotics are currently used in food production, far more than is used to treat people, with estimates of up to 80% of total antibiotic volume administered being used in farming. Using antibiotics for growth promotion in livestock or as replacement for good animal husbandry and hygiene practices is a massive concern. This almost certainly contributes to antibiotics, including those used by humans, becoming less effective. Drugs are used in farming at subtherapeutic doses, so bacteria are exposed to the antibiotic but not fully killed, thus selecting for resistant strains that survive and can pass on to humans. To make matters worse, antimicrobial use in farming is expected to be one of the fastest growing sectors. We have an increased global population plus eating habits shifting towards increased meat consumption. The global consumption of antibiotics in agriculture has been estimated at up to 240,000 tons, with an increase of 67% between 2010 and 2030. As well as familiar cows, pigs, chickens, or sheep farmed on land, hundreds of species of fish and shrimp are reared in aquaculture. Fish farming, aquaculture, is a rapidly expanding industry, and the use of antibiotics in this sector is generally unregulated in countries that account for the vast majority of fish farming. Those include China, Indonesia, India, Vietnam, and Bangladesh, and the Philippines, which account for 93% of global aquaculture production in 2016. However, there is some good news in the food production sector. In 2016, China introduced unprecedented policy change and banned the antibiotic colistin, which had been commonly used as a growth promoter in pigs, and they banned it from animal feed, but not actually from export. So the case for new vaccines for farmed animals, including fish farming, is strong, but we need to incentivize the uptake of existing vaccines. Farmers will adopt vaccines if it's an economic advantage to them, and if the method of getting them into animals or fish is convenient. So products need to be developed with the intended end user in mind. And the fantastic example I've got is how vaccines can help reduce the use of antimicrobials in the fishing industry in a sustainable manner. So a few years ago, I had the pleasure of visiting a fish farm in Norway, which truly was inspiring and eye-opening. They use antibiotics in aquaculture. And in Norway, they've decreased use by 99% between 1987 and 2013, with a 20-fold increase in production. And that was because of vaccines in the fish, a mixture of three. And vaccinating, they now do it robotically, though I vaccinate it by hand myself, in each and every fish. Secondly, vaccines for viral as well as bacterial diseases can help us reduce the amount of antibiotics used in human healthcare. Take flu vaccines as one example. Most people who die from flu die actually of bacterial chest infections rather than directly of the flu. So if they don't get the flu, they won't have bacterial infections. Inappropriate use of antibiotics in humans is certainly a major contributing factor to AMR. For example, antibiotics are often given for a viral infection or the wrong bacterial infection. Unfortunately, however, even appropriate antibiotic use contributes to AMR too. Haemophilus influenza type B, as well as Streptococcus pneumoniae, pneumococcal conjugate vaccines not only prevent life-threatening disease, but also reduce antibiotic use and therefore save lives and reduce AMR. These vaccines have resulted in a dramatic reduction in disease and have been associated with decreased circulation of resistant strains. Of course, both vaccines have an additional indirect effect on AMR by reducing antibiotic usage and therefore selection pressure on the pathogens as well. Currently, pneumococcal and rotavirus vaccines prevent 24 million and 14 million, respectively, cases of antibiotic-treated illness every year, respectively, among children under 5 in low and middle income countries. Increased coverage for these vaccines could prevent an additional 40 million cases of antibiotic-treated illness. And vaccines, I know from my time as Chief Medical Officer in the UK, are great value for money. But we need better ways to measure and therefore demonstrate that to the funders, the purchasers. We need to include the cost of an averted future AMR outbreak in our value assessment of a vaccine to further incentivize the development of them. Vaccines form a vital part of our toolkit against AMR, along with other important and systemic interventions. We're always going to need disease surveillance. Health providers, especially those in developing countries, have competing demands for their health budgets, and we all understand that. They need robust data to make up-to-date, data-driven decisions about which health interventions, such as vaccines, to fund and where to deploy them and to whom. We also need surveillance data to assess the success or failure of interventions, and the success of vaccines can be proved. The government of the UK funds the development of surveillance for AMR in low and middle income countries through the Fleming Fund, as well as through our Global AMR Innovation Fund. So, for instance, work funded by the latter enabled an AMR surveillance platform to be established in Zambia. The platform was designed to ensure burden-free implementation for health workers, no new data silos, long-term sustainability, and is open source. And it's this sort of bottom-up approach that enables data-driven decision-making in Zambia and beyond. Another example, in the city of Kano in Central African Republic, Médecins Sans Frontières have pioneered the rollout of mini labs. It's amazing. They've condensed lab equipment into a 20-meter square container that you can transport, and it's affordable, so clinicians can adapt treatments to the infections they are presented with. In December, the mini lab in Kano cultured about 380 blood samples. 12% were found to be positive for bacterial growth, of which 18% were resistant to antibiotics. MSF also trains local lab technicians to run and maintain the equipment and hope to expand to more countries in the coming years. Surveillance is important too in animals, you know. In response to the COVID-19 pandemic, I launched the Trinity Challenge, a new coalition of diverse partners committing to using data and analytics to generate and recognize the best thinking to contribute to a world better protected from health emergency. Our Trinity Challenge brought together public, private, social, and crucially, academic sectors to better identify, respond to, and recover from health emergencies. And I was thrilled by the first grand prize winner, which was Participatory One Health Disease Detection, or PODD, from Open Dream in Thailand. It's a solution that turns farmers into disease detectives, enabling them to serve as frontline surveillance systems to help prevent disease spillover from animals, and in turn for uploading photos of potential zoonotic diseases onto a mobile app, the farmers receive veterinary care to improve animal health. If it appears a disease outbreak is likely, the local health officials quarantine the sick animals, saving the remaining livestock and possibly preventing the next COVID-19 type outbreak. To date, PODD have worked with over 20,000 farmers in Thailand, and they're now, as prize winner, expanding their operations into Cambodia, India, Indonesia, Laos, Uganda, and Vietnam over the next 3 years. And that's going to help us link systems and countries together and should have wonderful benefits for AMR too. We need to develop and use vaccines in the food chain. We need regulations limiting the amount of antibiotic waste from manufacturing plants that can be discharged untreated into waterways. Earlier this year, a major study of over 250 rivers from over 100 countries found over 1/4 of these rivers were polluted to toxic levels. Your vaccines can help protect us from this. We really need to recognize that the data points to low and middle income countries being most affected, likely because the people in these countries can afford to buy medicines but lack expensive sewage systems to filter out the drugs. I was delighted in 2020 to hear of the Indian government considering draft legislation to limit the concentrations of antibiotics that plants can discharge through waste into the environment, and beginning to look at sewage. It was innovative, and we really need India to continue this endeavor and other countries to follow suit. We've also got to investigate the extent to which spraying crops with antibiotics is contributing to AMR. Tons and tons of streptomycin and oxytetracycline are sprayed on citrus trees to prevent citrus greening, a bacterial disease that spoils crops. They're being applied, absolutely literally, direct into the environment. Can you develop vaccines that work for plants and crops? We need new diagnostics as well. We need tests to tell us which bacteria are there and which antibiotic they aren't susceptible to. So, for us to truly succeed in our fight against AMR, we need researchers, policymakers, developers, healthcare workers, food chain people, all of us on this call and beyond to work together. COVID-19 has taught us the great value in having treatments that work, but it's vaccines that are really reducing the impact. Yet as it stands, WHO have gone so far as to say the world is failing on AMR because of the lack of treatments in development to fulfill critical public health needs. We've got a broken antibiotic market with only 2 antibiotics in the whole pipeline active against critical multi-drug gram-negative bacteria. Our global medicine cabinets are running empty. So we need vaccines to stop this happening. Staying one ahead of superbugs obviously needs global leadership from G7, G20, and G77 with health, and actually, much more importantly, finance ministers leveraging the investments and approaches we need for COVID-19. And I spent much of last year working with G7 countries to improve market conditions for antibiotic development. I challenged health ministers to work with finance ministers to look at the current lack of innovation. Our G7 finance ministers made commitments to address AMR, emphasizing the role of pull incentives. And in the UK, we've got an innovative Netflix subscription model, which has really shown the way that we can take this forward. And the Pasteur Act in the US is ready to establish a similar subscription model. But as we all know, from the vaccine world in COVID, as well as other things, public opinion counts too. It was welcome news that McDonald's are working to eliminate the use of highest priority, critically important antibiotics by 2027. Maybe vaccines could help them get there better and faster. I believe they can. And in the UK, 6 of the 10 leading supermarket companies have now banned the routine use of antimicrobials in their food supply chains. And I've seen how Purdue Poultry have used vaccines to remove antibiotics from their supply chains. This shows change can happen. We now need consumers to put pressure on suppliers as well by voting with their feet, changing the way their food is produced. From the UK, we launched the Investor Action on AMR initiative, calling on investors to commit to make sustainable investments and align with global best practice on AMR, bringing AMR into their economic, social, and governance ESG standards. And to date, 15 investors across the world with a collective asset portfolio of over 11 trillion have signed up. So it's clear AMR is complicated, going well beyond just being a scientific challenge. We've got to have behavioral change, we need political will, and as always, we need money. We need money for researchers to do that important work on bacterial vaccines. However, it can be hard to garner and then maintain action and attention for AMR, because AMR is essentially faceless. Unlike COVID-19, unlike HIV, TB, diabetes, cancer, there's not a distinct patient group to make noise and lobby for action. So we really need to use everyone we can. Let me reiterate what I said at the start as I finish now. Do not doubt that AMR can cause comparable devastation as COVID-19. Rising drug resistance could lead to an additional 19 million people in low and middle income countries falling into extreme poverty by 2030 due to the impact of AMR on labor productivity and healthcare costs. We have to address the spread of AMR before the catastrophe hits. No one nation or sector can tackle this alone. It's critical we encourage public, private, and third sectors to work together to tackle this challenge. And vaccines are going to play a major role in this war. Thank you.
Thank you very much, Dame Sally. That was really an excellent and inspiring talk. I think for the interest of time, we're going to go straight ahead though, no Q&A at the moment, but towards the end. And I understand that there will be recordings available, transcripts, and et cetera. We're not actually going to the panel discussion yet. We have actually, the first speaker will be Ramanan, who, the agenda is just going randomly, but that's okay. Who's going to talk to us about the importance of AMR and the mechanisms through which vaccines prevent it. I think if we can queue up Ramanan's talk, please, Alex.
Good afternoon, everyone. It's a pleasure to be speaking about the importance of AMR and the mechanism through which vaccines can prevent this problem. And these slides are really on behalf of the Antimicrobial Resistance and Vaccines Modeling Consortium, or RVAC. I think we're all quite familiar with AMR being an issue for a few decades now, but things actually getting worse over the last 15 years or so. With the emergence of multi-drug resistance and the dissemination of multi-drug resistant strains globally. At the One Health Trust, we have developed this drug resistance index that we've now been tracking for almost 20 years. And this is basically like a stock market index of resistance to different pathogens weighted by how frequently the antibiotics that are used to treat that particular pathogen. And as you can see, resistance is already pretty high in countries like India and Turkey, getting worse in places like Greece, Italy, the UK, Australia, and holding steady or getting slightly better in Sweden, for instance, but Sweden is certainly an outlier in this regard. Now, the information from the University of Washington, based on a small amount of data from around the world, but a lot of extrapolation, but still the best estimates that we have right now for the burden of resistance indicate about 1.3 million deaths attributed to antimicrobial resistance each year, and a much larger number, or nearly 5 million deaths associated with antimicrobial resistance. This ranks pretty highly in terms of global burden of disease and numbers of deaths. And if we were to count just infection diseases, AMR would rank number 3 after COVID and tuberculosis. And as COVID sort of wanes, AMR will be number 2, well ahead of both HIV, AIDS, and malaria, both diseases that attract significantly more attention and finances than AMR does. Now, about a quarter of deaths associated with drug-resistant diseases are due to antimicrobial resistance. So the light blue on the right represents the proportion that are due to antimicrobial resistance. And although, again, I should emphasize that these are based on modeled estimates from the University of Washington, they still indicate that a significant burden of diseases, infectious diseases, are due to infections that are no longer treatable in many parts of the world. The estimated global burden of resistance is concentrated in South Asia and Sub-Saharan Africa. In these estimates, access to antibiotics plays a role in exacerbating the problem of resistance. So in West Africa, for instance, it's difficult to tease out how much of that is simply because of higher levels of resistance and prevalence of infectious diseases, and how much is because people are not able to afford the antibiotics that may be available in high-income countries in order to treat that particular infection. So access is a particularly significant part of the resistance problem. There have been many reports over the years that have talked about vaccines in the context of AMR. They go back all the way to the 1980s with the Office of Technology Assessment report, which has an entire section on the role of vaccines in tackling AMR. The CDEP report, Extending the Cure, which again dealt with this at great detail back in the early 2000s. More recently, there's been work, including a meeting in 2017 at Chatham House. But what was notable about the meeting was really the fact that even with many speakers present who knew about the subject, there were very few actual estimates on the actual burden of AMR that could be averted using vaccines. And following that, there was a report that was done by BCG for the Wellcome Trust, which I'll talk about in just a little bit more. Now, vaccines have been noted as a way of tackling antimicrobial resistance, including the Global Action Plan, but admittedly, this has been more aspirational and rather sketchy on detail. Since then, there has been a consortium that's been working on vaccines and AMR, and this is the RVAC consortium that includes a number of universities and includes the CDEP, which is now called the One Health Trust, and a set of papers that have been published since 2020, starting with the one in Nature on childhood vaccines and antibiotic use, which is, I would say, the largest study to date on looking at the role of pneumococcal and rotavirus vaccines in tackling AMR, followed by other studies looking at typhoid, influenza, and also tuberculosis. And now we have new studies coming out on Klebsiella and also malaria and HIV vaccines when they should come about. So this is the paper on the tuberculosis, the burden of drug-resistant to TB avertable through post-exposure vaccines. Now, going back to that Wellcome Trust report that was done by BCG, now that report basically categorized vaccines or pathogen clusters in the following way. Those for which vaccines already existed, for which the need of the hour was to increase uptake. So this would be Haemophilus influenza, Streptococcus pneumonia, and Salmonella typhi. Bringing to market would require more work on E. coli, NTS vaccine, and also Shigella. And there were other vaccines that were in earlier stages of development. Now, this particular ordering has changed somewhat even in the last couple of years since this report has been published. So, for instance, the Klebsiella vaccine is probably further along than this report would have observed or projected. And there hasn't been as much progress made, for instance, on, say, Pseudomonas vaccine, for instance. And these were really based, so the prioritization of vaccines was really based on the WHO global priority list with critical vaccines about Pseudomonas, Acinetobacter baumannii, Klebsiella, and so forth, and medium priority being pneumococcal, Hib, and Shigella, because there are already vaccines available for this. But again, there's been some reordering of this with the new emerging evidence. And if we look at the probability of R&D success on the x-axis and health impact, which is measured by mortality, morbidity, and AMR threat on the y-axis, you have the vaccines that are already licensed and available, but you do have some idea of which vaccines may be important to have, but which are also likely to be coming into market relatively soon. So the RVAC consortium, as I mentioned, includes Princeton, CDEP, Berkeley, Imperial College, and also Yale. And the main question being asked here, what is what the role of vaccines is in reducing the burden of antimicrobial resistance. In a really nice paper written by Katie Atkins and colleagues, which looked at pathways through which vaccination against focal bacteria and non-focal bacteria and viruses can control antibiotic resistance, you see a number of pathways, whether it's focal or non-focal. And the pathways are fairly complex. They operate at the direct level, but also the population, pathogen, health, and the care level. Now, what we did was we crunched this entire fairly complex rubric, which is an excellent rubric, by the way, if you really want to understand all the pathways by which vaccines can help impact the problem of AMR, into just this, which is vaccination results in fewer infections, which work in one of two ways. You have less disease burden, less transmission, and therefore you save lives, and or you also have less antibiotic use and reduced selection pressure, which also saves lives. So you have fewer infections needing antibiotic treatment, fewer drug-resistant infections, therefore needing the more newer antibiotics, the last resort antibiotics. You have fewer viral infections for which antibiotics are used inappropriately. And then you also have fewer viral infections for which you have secondary bacterial infections for which antibiotics may be needed. Now, that vaccines are remarkable in reducing the burden of disease requires no major argument. We've known that, for example, diphtheria cases in the United States just plummeted after the introduction of the vaccine way back in 1940. Similarly, the introduction of the pneumococcal conjugate vaccine, PCV7, in 2000 resulted in a decrease in invasive disease and both susceptible and non-susceptible disease right after introduction. And this is in the target age group of children, because children were at that time the single largest consumers of antibiotics in the United States and certainly in many other countries. And you could see that this worked in all age categories, not just in the 2 to 4 year olds, but you also had an impact on incidence in adults, the elderly population that was not receiving this vaccine. So vaccinating the kids had an across the board effect on reducing the incidence of invasive disease, but it also resulted in reducing the numbers of prescriptions and ambulatory care visits. So just from acute ear infections, the number of antibiotic prescriptions written dropped nearly 40%. And this is in the United States, but similar results have been noted in other parts of the world as well. Now, we know that the flu season is not just a key driver, it's probably the most important driver of antibiotic consumption in many parts of the world, particularly in temperate countries where the flu season in December, January, February can result in a lot of antibiotics being prescribed. And the same pattern repeats itself in the southern hemisphere in the July, August, September, winter months there. And vaccines against viruses could reduce antibiotic use. In the US, about a fifth of influenza patients were prescribed antibiotics, even though nearly 4/5 of this group had no evidence of a secondary infection. So antibiotics are widely misused for patients at the time of the flu. Influenza vaccination can reduce antibiotics prescribed to unvaccinated household contacts by 88%. This is to unvaccinated household contacts. So there's secondary benefits that are really important. And it's not just against this. So even if you look at antibiotics for Group E strep, for instance, prophylaxis. So any sort of prophylaxis does have the secondary damage for bystander species. And you have the increase in GBS isolates, resistance to clindamycin and erythromycin over the last 20 years. Now, in a study that we did a few years ago, we found that influenza in the United States is nearly perfectly predicted by antibiotic sales data. In other words, if you knew the antibiotic sales, you could tell how bad the flu season was in any given year. And that's not very good news. It just means that antibiotics are really tracking influenza rather than being used appropriately, even in a country like the United States, which requires prescriptions for antibiotics. Now, we know that antibiotic consumption is a major driver for resistance, at least in high-income countries. So this is a study from, again, US data. It's almost, it's a 1 to 2 month lag between prescriptions and resistance. And there was another study, which is quite well known by Herman Goossens and colleagues in 2005, which showed that use and resistance were tightly correlated when you were looking at penicillin use and the prevalence of penicillin-resistant Streptococcus pneumoniae, and this very nice 45-degree line that you could see, France at one end and the Netherlands at the other end, and France being a high consumer of antibiotics and the Netherlands being a low consumer of antibiotics. Now, this pattern of correlation between antibiotic use and resistance is not repeated in other parts of the world. So in this study that we did looking at resistance in low and middle income countries, what we find is that there's very little correlation between antibiotic consumption and resistance. So although we definitely want to reduce consumption, reducing consumption is not going to be the only solution in trying to solve the resistance problem. With that, I'd like to stop and thank the organizers for the invitation to present. CDEP is now the One Health Trust, and this is our new website, which should be up soon. And happy to take any questions now or during the panel discussion. Thank you.
Thank you very much, Ramanan. I think we're going to leave the questions for the end, but there's a very active discussions going on in the Q&A. So please actually put your questions in the Q&A box, not in the chat, and we will, some of them are being answered in real time by our panel of experts, but others I think we'll talk at the end. I would like to then move to our next speaker, who is Mateus, from the WHO, who will be talking about a relatively new initiative for the WHO to describe more quantitatively what is the value of vaccines in reducing resistance, which I think personally is crucial for being able to convince people that vaccines have a role. You have to say, well, what is the role, not just they're good to have. So I'd like to let Mateus go ahead.
Good afternoon, colleagues. I am Mateusz Hasa-Gobsowicz. I work in the immunization department at the World Health Organization. And today I'll try to convince you that vaccines play a role when reducing antimicrobial resistance. Allow me to start by explaining that antimicrobial resistance is a key component of the full value of vaccines. The role of our team at the World Health Organization is to facilitate the development of vaccine candidates which have perceived value in low and middle income countries and often limited commercial incentive because of the primary use in low and middle income countries. So in order for us to prioritize the development of these vaccine candidates so that it can inform the introduction and use, we really need to articulate the full value of vaccines in its full capacity. And when I say full value of vaccines, what I mean by that is that the value of vaccines can be measured across numerous criteria, and that's beyond mortality. We can see that on the graph on the right-hand side, where we can see mortality, morbidity, impact on antimicrobial resistance, on economic burden, equity and social justice, microbiome, and many other examples of impact of vaccines. We know that AMR is a growing threat, is causing many deaths, it is costly, and has capacity to undermine many aspects of modern medicine. Therefore, AMR is an important aspect of this value of vaccine assessment. And to note that this whole idea of value of vaccines, full value of vaccines, has been explained in the Immunization Agenda 2030, a global strategy for the next decade. To further highlight the value of vaccines in preventing antimicrobial resistance, WHO earlier in 2021 has published the action framework to leverage vaccines against antimicrobial resistance and antimicrobial use. This is a technical document which is a strong high-level statement from WHO that summarizes the need to realize the full potential of vaccines in the fight against antimicrobial resistance. It includes actions that are relevant to stakeholders, colleagues from organizations, from pharmaceutical companies, from the research community, and actions are structured around 3 strategic goals. The first strategic goal is to expand the use of licensed vaccines to maximize their impact on antimicrobial resistance. And here we talk about using vaccines such as Streptococcus pneumo, typhoid conjugate vaccine, or HIP, to ensure that optimal coverage is met and there is impact on antimicrobial resistance. The second strategic goal is to develop new vaccines that contribute to prevention and control of AMR. And here we talk about exploring feasibility of developing vaccines against pathogens that are on the high list of threats by WHO, like Pseudomonas, like Acinetobacter. The third strategic objective is to expand and share knowledge of vaccine impact on AMR. Here we talk about the need to fill in data gaps, to conduct primary research, to collect data, and also to conduct modeling estimates to better understand the impact of vaccines on antimicrobial resistance. Subsequently, all of the actions that are happening within our department in WHO that relate to vaccines in AMR are structured around these three strategic goals. In WHO, we wanted to build up on the Wellcome analysis, and we wanted to assess what is the value of vaccines specifically in preventing and reducing antimicrobial resistance. We're doing this work because we want to synthesize the best available evidence of the impact of vaccines against AMR. We want to highlight what are the knowledge gaps, what additional research needs to be done to fully understand the impact of vaccines against AMR, with the overarching goal to prioritize vaccine development and use. However, as we were going through the exercise, we realized that assessing the value of vaccines against AMR is very complex. Firstly, because there's very limited understanding of the burden of AMR, and also in some cases the susceptible disease burden. The impact of antibiotic consumption on resistant is hard to measure, and there is paucity of data, especially coming from low and middle income countries. It's difficult to predict future resistance patterns, and also we need to ensure that we present vaccines in the context of other approaches to contain antimicrobial resistance, such as WASH. We also need to discuss the feasibility of developing vaccines. So what is the biological feasibility, product development feasibility, but also access and implementation feasibility. So when we talk about the value of vaccines in reducing AMR, there are a number of criteria that we consider. So first one is, what is the vaccine averted AMR associated health burden? And here we want to know what is the number of infections or deaths that are caused by resistant pathogens, and the proportion of these infections or deaths that could be averted by a vaccine. We also want to know the economic burden. So what is this incremental cost of treating a resistant infection versus drug-susceptible infection? And what proportion of that cost could a vaccine avert? We also would like to know what is the antibiotic use associated with a particular pathogen, and what proportion of this antibiotic use could be averted by a vaccine. We also want to know what is the urgency of some of these resistant threats. How have they been changing over the past decade? What is the number of treatments that we have available, and how urgently do we need to act to introduce approaches to contain antimicrobial resistance? And lastly, we want to express the value of vaccines beyond standard measures of burden, of economic burden, health burden, and we want to look at the impact of pathogens on underprivileged populations and the impact that pathogen has on agency and association and respect. I'll now show you some of the examples of the results that our colleagues or us, together with collaborators, had done to inform some of the criteria that I've mentioned on the past few slides. This is the analysis that was published in The Lancet by colleagues from the Yale University, where they looked at the impact of typhoid conjugate vaccine given in a routine immunization setting, firstly given to children at 9 months of age, with a one-time catch-up campaign up to 15 years of age in Gavi, 73 countries. They have found that such a vaccine, such a campaign, would avert 342,000 deaths from multi-drug resistant typhoid over the next 10 years. So a really high number and high impact from multi-drug resistant related deaths. And we can see where these deaths will be prevented on the graph on the right-hand side, which is the predicted impact of this vaccine on incidence of multi-drug resistant cases of typhoid fever. And we can see that majority of these averted deaths would come from sub-Saharan Africa and India, and then the region of Oceania. We had also conducted analysis that were looking at pathogens more broadly. And a lot of you might be aware that earlier this year, IHME and the Global Burden of Disease Studies has released estimates of antimicrobial resistance for 2019 across a number of pathogens. What they have found is that they confirm that AMR is a global threat with 1.27 million deaths attributable to bacterial AMR and 4.95 million deaths associated with bacterial AMR worldwide in 2019. What they mean by attributable is if all the deaths were replaced by drug-sensitive infections, and what they mean by associated is that if all the deaths were replaced by having no infection, which is what is important for a vaccine. What they have found is that the top 3 pathogens that were causing the largest number of attributable and associated deaths with resistance were E. coli, Staphylococcus aureus, and Klebsiella pneumonia. So what we did going forward is we collaborated and worked closely with an IVI, LSHTM, and IHME so that we could model impact of vaccines on deaths and DALYs associated and attributable with resistance for 15 pathogens that were part of the IHME analysis. We identified a number of vaccine assumptions, and we had identified them based on known vaccine attributes for licensed vaccines. For vaccines in development, we looked at WHO target product profiles or preferred product characteristics. For others, we look at late-stage candidates and what such a vaccine would look like, what attributes it would have. Or we also consulted with many experts to ensure that our assumptions are feasible and appropriate. And these assumptions included efficacy, coverage, duration of protection, target group, or disease or strain prevented. And we applied them to IHME results to calculate the estimated impact of vaccines across the pathogens measured in IHME. Here you can see some of the results on the graph on the right-hand side. So the y-axis shows you the vaccine avertable number of deaths, in light blue associated with resistance, in dark blue attributable to resistance, and on the x-axis you can see various pathogens and vaccine profiles with appropriate assumptions that were applied to conduct this analysis. I'll give you some examples of the results. So the first one is a vaccine for Streptococcus pneumonia. This is an improved vaccine that would have 50% efficacy against lower respiratory infections and 70% efficacy against all the presentation and strains of Streptococcus pneumonia bacteria. Such a vaccine would avert 123,000 deaths associated with resistance. Another example is a vaccine for Mycobacterium tuberculosis. This is a second profile of an MTB vaccine from a WHO preferred product characteristic document, which describes a vaccine with an 80% efficacy given to 10 years old with a lifelong protection or boosting if required. And such a vaccine would avert 118,000 deaths in 2019. And then another example is a vaccine for Klebsiella pneumonia. This is a vaccine with 70% efficacy against all presentations of Klebsiella pneumonia infection given to infants, and such a vaccine would avert 64,500 deaths associated with resistance. These results of this analysis are available at preprint, and I welcome you to have a look at the article and give us your thoughts on the proposal. Switching gears, we also wanted to assess what will be the vaccine avertable antibiotic use. And firstly, we had conducted more of a pan-pathogen analysis to be able to understand that. We started with estimating pathogen-specific antibiotic use by firstly conducting systematic reviews to understand syndrome-specific antibiotic use in community. To understand syndrome-specific antibiotic use in hospitals, we had a collaboration with the Global Point Prevalence Survey study, and we then applied microbiological attribution of syndromes to pathogens. Later, we are now in the process of applying vaccine-specific attributes that I had listed on the previous page, the assumptions around vaccine coverage, use case, and efficacy, so that we can calculate the proportion of the antibiotic use that could be prevented by vaccination. And this is an early insight into the results. which show antibiotic use in community in Sierra and in the Wipro region, so in Southeast Asia and in the Western Pacific region. What you can see on the graph on the left-hand side is the proportion of prescriptions across antibiotic classes that were prescribed for a number of indications, which you can see on the y-axis. On the graph on the upper right side, you can see the proportion of antibiotics that were prescribed for a given indication across WHO regions. And what you can see on the graph, on the lower graph on the right-hand side, is the proportion of antibiotics that were prescribed for a given indication across age and across sex. Also, some of the analysis conducted by our colleagues, such as from the Berkeley University, estimated the impact of existing vaccines, such as pneumococcal vaccine and rotavirus vaccine, on antibiotic use. What they had estimated is that annually in under 5 in low and middle income countries, pneumococcal infections are estimated to cause around 57 million antibiotic treated episodes. And under current coverage of the pneumococcal conjugate vaccine, we prevent around 24 million antibiotic treated episodes. However, if we were to expand PCV coverage to its universal levels as recommended by WHO, we would be able to avert additional 22 million antibiotic treated episodes. Similarly, for rotavirus, currently we estimate that rotavirus infections cause around 48 million antibiotic treated episodes annually in children under 5 in low and middle income countries. With the current coverage of rotavirus vaccines, we prevent around 13.7 million of these antibiotic treated episodes. However, if we were to expand rotavirus vaccinations to the universal global level, we would be able to avert additional 18.3 million antibiotic treated episodes. And you can see that on the graphs on the right hand side. The top one is for PCV, the bottom one is for rotavirus, and you can, if you're interested in these results, you can look at the Nature publication that summarizes them. We have a link in the slides. I also wanted to touch on the impact of pathogens on equity and social justice. We included this criteria because we believe that in addition of measuring the impact of vaccines and impact of pathogens on economic burden, health burden, pathogens affect disproportionately underprivileged populations across three criteria, such as agency, ability to pursue life plans so that we can make meaningful choices, identify values, form beliefs, and engage in reasoning. Association, so our ability to participate in social groups and community life, and also to build meaningful relationships. And respect, so respect that we have towards self, our identity, and also social respect that we received from community. And on the right-hand side, you can see a summary of such an analysis for Acinetobacter baumannii, where we see that the impact of such pathogen on agency, long hospitalization can exacerbate economic anguish for families that already lived in poverty. For association, long hospitalization may impact social lives, loss of trust in health systems, inability to participate in social and community life. Prolonged isolation can also cause distress and mental breakdown. For respect, untrained bedside carers may be stigmatized if a nosocomial infection is linked to poor hygiene. And we estimate that particularly vulnerable groups for these three dimensions are low-income families, bedside carers, their patients, other hospital patients, and low-resourced healthcare settings. So to conclude, AMR is a key component of the full value of vaccines. It needs to be systematically articulated whenever we make decisions about vaccine development, introduction, and use. We have the global burden of disease estimates, which really improve our understanding of the burden of AMR. However, it's important to know that they have limitations given the paucity of data coming from low and middle income countries. Vaccines reduce resistant infections and deaths, and we had examples for pneumococcal vaccines, typhoid conjugate, and TB vaccines. They prevent antibiotic use. We showed some examples for rotavirus and PCV. and they can also impact equity and social justice, often exacerbated by antimicrobial resistance. And I gave you an example of Acinetobacter baumannii. And to conclude, allow me to acknowledge our partners, our colleagues. So One Health Trust, Berkeley, International Vaccine Institute, IHME, the Working Group on Vaccines and AMR, a group of experts, London School of Hygiene, Tropical Medicine, the Gates Foundation, Johns Hopkins University, Yale University, Wellcome, and also Institute of Development Studies. Thank you so much for your support and your expertise that you have provided towards this project.
Thank you very much, Mateus. And I think there's a lot of very good discussion going on in the Q&A section, so take a look there as we move on to our next speakers. We have the next part of our session is 3 short presentations on specific vaccines. 2 of them are on specific sets of vaccines and the kind of impact that has been potentially could be measured or will be measured. The first talk is by, I believe, Liz Rogowski, and these are, again, a series of short presentations, which...
Thank you for the opportunity to present progress on our work funded by Wellcome to estimate the impact of vaccines for enteric pathogens on antibiotic use among children in low-resource settings. I'm Elizabeth Rogowski-McQuaid, an assistant professor of epidemiology at Emory University. Children in low-resource settings have a high burden of enteric infections. Frequent antibiotic treatment results in exposure both to the target pathogens of treatment, those that are causing diarrhea, as well as other pathogens carried asymptomatically. This results in frequent selective pressure for antibiotic resistance in this population. Enteric vaccines will be a key tool to combat AMR by reducing the incidence of bacterial diarrhea episodes, reducing inappropriate antibiotic use for viral diarrhea, and reducing antibiotic exposure to asymptomatic infections, which are not the target of treatment. This we term bystander antibiotic exposure. In this work, we aim to quantify the incidence of antibiotic use resulting from diarrhea treatment in MALI-D, an 8-site birth cohort study.
Excuse me, this is for the Spanish translator. I think you left your booth and you are on the English channel. Can you please go back to the Spanish booth? Thank you.
We also aim to estimate reductions in the incidence of antibiotic use that would be achievable by vaccines against Shigella and other enteric pathogens. I will present preliminary estimates for Shigella vaccines today. The MALI-D study was an observational birth cohort of approximately 2,000 children conducted in 8 low-resource settings in South America, South Asia, and Sub-Saharan Africa. The cohort was followed closely with twice-weekly home visits from birth to 2 years of age. Therefore, we have information on antibiotic use and diarrhea episodes that occurred on every day for 2 years. Furthermore, stool samples were collected and tested for enteric pathogens by quantitative PCR. First, we quantified the absolute incidence of antibiotic use that was attributable to specific causes of diarrhea. Shigella was the leading cause of antibiotic treatment, responsible for 15 courses per 100 child years, and was the leading cause for all drug classes except penicillins, shown in the red bars on this graph. Enteric viruses, including rotavirus, sapovirus, and adenovirus, are the next most common causes of antibiotic use, despite the fact that viral diarrhea should not be treated. We also quantified the amount of bystander exposure to antibiotics that could be attributed to the treatment of specific causes of diarrhea. Bystander exposure is when bacteria are exposed to antibiotics when they are present asymptomatically and not the target of treatment. Bystander exposure was extremely common and is shown here for several types of diarrheagenic E. coli, as well as Campylobacter and Shigella. This graph only shows bystander exposures due to diarrhea treatment, but Enteroagrida E. coli, for example, was exposed to antibiotics more than twice per year on average when it wasn't the target of treatment. This figure shows that Shigella and rotavirus were the leading etiologies responsible for bystander exposures for all bacterial pathogens. For example, Shigella accounted for almost 20% of bystander exposures to fluoroquinolones. Given the impact of Shigella on antibiotic exposure, we estimated the reductions in antibiotic use in the first 2 years of life that could be expected after the implementation of a Shigella vaccine. In the hypothetical scenario presented here, the vaccine is simulated to have 60% efficacy and is given at 9 and 12 months of age. We simulated partial protection after the first vaccine dose and some waning immunity. We would expect a 46% reduction in fluoroquinolone and macrolide treatments for Shigella diarrhea episodes and a 9% reduction in treatments for diarrhea overall. The Shigella vaccine would be expected to prevent 3.5% of all fluoroquinolone and macrolide treatments, as well as 3.9% of all bystander exposures to fluoroquinolones and macrolides for asymptomatically carried bacterial pathogens. In conclusion, we found that specific diarrhea etiologies were responsible for a substantial amount of antibiotic exposure, even when the pathogen was not the target of treatment. However, each individual enteric pathogen accounted for a relatively modest proportion of all antibiotic exposures among these children. Enteric vaccines such as the Shigella vaccine would result in measurable and likely important reductions in antibiotic use. But given how common antibiotic use is in this population for other illnesses, particularly for respiratory illnesses, the impact on the development of antimicrobial resistance overall is unknown. I would like to especially thank Stephanie Brenhofer at the University of Virginia, who led these analyses, as well as co-investigators at the University of Virginia and UC Berkeley. I'd also like to thank the larger MALAD network and participants, as well as welcome for funding this work. Thank you.
Thank you very much, Liz. Our next speaker will be Rob Heiderman, who's going to talk about pneumonia or pneumococcal and malaria vaccines in Malawi.
This is a recording by Rob Heiderman for the WHO Symposium on Antimicrobial Resistance and Vaccines. I'm sorry that I can't be with you in person today, but I'm really grateful to the organizers for the opportunity to share some of our work on the interaction between vaccines and antimicrobial resistance. I'm sure you've heard about the multitude of potential modulators of antimicrobial resistance, including vaccines, but also a range of host and pathogen factors, environmental factors, antimicrobial use itself, and then a range of secular and random effects that add to the complexity of this interaction. Studying the impact of the introduction of the pneumococcal vaccine, PCV13, on an urban population in Blantyre, Malawi, based at the Malawi-Liverpool Wellcome Trust Programme. The vaccine was introduced in 2011, and in work led by Todd Swarthwaite and Tandy Monacomo, in a series of carriage surveys in a population with a high vaccine uptake, we've demonstrated persistent carriage of vaccine types in children aged between 3 and 7 years of age, representing a potential reservoir of vaccine escape. To understand this further, Todd's been analysing serosurveillance data, looking at vaccine antibodies. This is the percentage of individuals that reach putative correlates of protection for invasive pneumococcal disease and for pneumococcal carriage in the broken lines from 0 to 100% in children less than 3 months through to 4 years of age. Red line represents 50%. So as you can see, across a range of serotypes, whilst a vaccine boosts, there is clear evidence of waning immunity with the population immunity dropping below 50% for multiple serotypes by the second year of life. These are 2 serotypes that aren't in the vaccine for comparison. To understand this further, in work led by Andrea Gori, we've undertaken a whole genome sequencing analysis of the pneumococcal isolates that come from these surveys. Within this complex population structure, Andrea has identified particular genotypic profiles that have emerged with specific virulence characteristics and also increased MICs to penicillin emerging over time. Now, whilst we can't say that this has been induced by the introduction of vaccine, this has occurred over the same period of time. And to analyze this in greater detail, we've been undertaking studies of the impact of pneumococcal vaccines on the prevalence of antimicrobial resistance amongst pneumococcal isolates and the frequency of febrile illness and antimicrobial usage. So looking at the direct and indirect effects of vaccine introduction in the context of evaluations being conducted by the Ministry of Health in a cluster randomized way on the PCV13 from 3+0 to 2+1, and the introduction of the RTSS malaria vaccine in Blantyre district and Mangochi district, which is on the Malawi lakeshore. Now, because of COVID, I don't have data to share with you at present, although this data is being accrued at the moment. I can say from our baseline surveys is that the knowledge and exposure to antimicrobials amongst children less than 5 is very high. So at health centre antibiotic surveillance, we've demonstrated antibiotic prescribing for health centre attendances anywhere between 60 and 90%, varying considerably between urban and rural settings, and also considerable recognition during household surveillance using a drug bag approach developed by Claire Chandler at the London School, demonstrating knowledge of antibiotics, both oral but also injectable antibiotics accessible through informal and formal systems. So really, our analysis is going to have to take into account these multiple complex factors in order to really understand the interaction between vaccines and antimicrobial resistance. I would like to stop there by particularly thanking Todd Swarthwaite, Neil French and Aku Kalazingoma from the Welcome Programme in Malawi, Ken Maletta from the Kamuzu University for Health Sciences, colleagues at the Malawi Ministry of Health, Charles Wansambo and Storm Kabaluzi, Andrea Gori from UCL and David Singleton from the University of Liverpool, and David Goldblatt's lab here at UCL. I would also like to thank our funders.
Thank you very much, Rob. Our final short presentation will be by Lanling Zhou at the NIH, who's going to talk about NIH antimicrobial resistance priorities and programs.
Hi, my name is Lanling Zhou from the National Institute of Allergy and Infectious Diseases. I will present to you an overview of our Institute's AMR priorities and programs. Next. As described in our AMR research framework, as a funding agency, we support research in basic science, translational projects, product development, and clinical studies with the objectives of developing diagnostics, therapeutics, and vaccines. We list several strategies here and encourage innovative approaches to address AMR's challenges. Next slide. We have various funding mechanisms. In addition to regular investigator-initiated grants, we offer preclinical services for early product development and clinic networks for studies in humans. To address specific research gaps and urgent public health needs, we regularly put out targeted initiatives. These projects are usually funded by cooperative agreement or contracts. Next slide. For vaccine development specifically, we offer several animal models for escape pathogens and one mouse model for Neisseria gonorrhea. We also provide reagents, assays, manufacture, and clinical trial and regulatory support. Next slide. Now I'm going to share some of our ongoing projects. First, the vaccines for Staph aureus infections. As we know, Staph aureus presents multiple variance factors and can cause severe infections. Currently, we are supporting several projects at the preclinical stage. One is the combination of modified toxins and superantigens by integrated biotherapeutics. The second one is a modified surface protein A, SPA-A, by ImmuArts and the University of Chicago. SPA-A in its native form invades and suppresses host immune response, contributing to its pathogenesis and a disease process. But the modified SPA-A lost its immune suppression. Instead, it stimulates host to generate protective immunity. Hence, it is being developed as a vaccine candidate. Next slide. Here is the project of a synthetic peptide vaccine against infectious by Neisseria gonorrhea. Its unique peptide mimics lipooligosaccharide structures and is protective in mouse vaginal colonization model. Next. 4-component meningococcal serial group B, MAN-B vaccine is authorized for preventing meningitis B outbreak. The clinical evidence indicates cross-protection against gonococcal infections. There is an ongoing clinical trial to evaluate its efficacy against urogenital and/or anorectal gonococcal infections. Next slide. As you know, bacterial Shigella species causes extremely drug-resistant infections. Here are 2 vaccine candidates that are being developed and tested in controlled human infection models. The first one is live attenuated WRSS2, developed by Walter Reed Army Institute of Research. The second one is a live attenuated combined vaccine against Shigella and ETEC, developed by Everliquel Biotechnologies. Next slide. This concludes my presentation. Please feel free to contact me or other program officers if you have any questions. Thank you for your attention.
Thank you very much. I think this concludes the first part of our presentations, but now we have a panel discussion. And I think most of the Q&As I think have been dealt with actually in the Q&A section. But if we could have the people who are part of the panel discussion, Ramanan, Laxminarayan, Cal McLennan, Padmini Srikanthia, and Carolyn Deal to show yourselves, please, that we know that you're really there and not a bot. I know you're not bots. Before we begin, I would like to, the purpose of this panel discussion is, as it says there, to talk about what are the priority research gaps. But I wanted to ask Ramanan a question that was raised by your presentation, in which you had shown the correlation with Herman Goosen's classic paper between antibiotic use and resistance in Europe, but then subsequently in other areas said it's not there. So why isn't there a correlation, a good correlation?
So this is just a hypothesis, Bill, which is that in high-income countries, all the other pieces of water sanitation, vaccination, infection prevention are all in place. So antibiotic selection pressure plays a major role in the emergence and spread of resistant infections. And that's why you see that correlation. The hypothesis is that low and middle income countries, because transmission of existing resistant pathogens is a bigger issue perhaps, that resistance can emerge anywhere and rapidly spread everywhere. So the link between antibiotic consumption, selection pressure, emergence of resistant pathogens, and then actually seeing that everywhere is a much weaker link, because transmission is potentially a more important mechanism for levels of resistance. Now, again, we have no way of confirming this, but we do see repeatedly that the link between antibiotic consumption and resistance is tight in high-income countries. and gets weaker as the income status of the country goes down. And particularly if health governance and other public health indicators go down, then that link becomes even weaker.
So the obvious question is, what does that do to the messaging about decreasing antibiotic use to decrease resistance? How do you finesse that?
I think the messaging is that we've just got to be transparent. I think we have to say that using vaccines alone is not going to solve the problem of AMR, but it's going to be a very important tool as a way of reducing antibiotic consumption, because you've got other sort of pressures for antibiotic consumption in low and middle income countries. So if you can avert illness, the big thing you do is you reduce the reason for giving out the antibiotic in the first place, which is really the best thing that you could really have. If you don't have an infection, you don't have a resistant infection.
Okay. I think this personally, in my view, and I'd be interested what others think, is a challenge, and how to calibrate the messaging about what is the role of vaccines here for antimicrobial resistance without overstating it, because we like to talk about vaccines, or people do, as magic bullets, but without understating it too and saying it's really minor. So I do think this is the challenge. I wonder if other people have either thoughts on this or on just the overall question of what you see as the priority research gaps here to understand. Maybe we'll start with that. Start with Cal. What do you see as the research gaps that you really think are the most important for getting at this issue of vaccines and AMR?
Many thanks, Bill. And my name is Cal McLennan. I'm the director of Back2Vac, the Bacterial Vaccines Network. So this is an issue very, very close to the heart of our mission. I think one of the things that's come out through the talk so far is the lack of data from LMICs, and the fact that a lot of our information that's been guiding estimates, etc., have come from high-income countries. So there is the gap there. But I think one of the things I'd like to just focus on is, in terms of the WHO priority pathogen list, only 3 of those have vaccines, and even with the candidates which bring to market, we're looking at another 6 to 8 years for the ones that are most advanced. So we do have to bring the vaccines forward that we need, and that isn't easy at the present time. COVID hasn't helped us. It's stopped work on other vaccines. It's taken a lot of valuable workers away, and it hasn't sort of really solved the problem that there is a gap of funding for vaccines against AMR, which are unfortunately seen by the multinationals largely as not being of great commercial attractiveness. So I would focus on the need to make sure that we're bringing forward the vaccines against those AMR pathogens, because it's a long haul. And with typhoid conjugate vaccine, WHO in 2008 said we've got TCVs just around the corner. It took another 12 years before they were there and pre-qualified.
It took another 12 years, but also it took probably an XDR outbreak of typhoid to get things really moving, which is kind of paradoxical.
Well, when you've got the need, as we found out with COVID, it certainly helped shift things along, and that was right place, right time. And actually the data that were generated from that study are fantastic, because they show in real time the impact that that vaccine had, not just on typhoid, but on XDR typhoid.
Yeah, it's really, I think it's underrepresented, that data in Pakistan. Padmini, what do you think? Where would you focus your research efforts, or do you focus them in this area?
Yeah, thanks, Bill, and thanks to the organizers for inviting me to join the panel. My name is Padmini Shrikantaya. I am a deputy director in the Global Health Division at the Bill and Melinda Gates Foundation, where I lead the AMR strategy. And our AMR strategy is very much focused on prevention with vaccines, very much at the center of the strategy. And first, I'd like to start by saying, I think we've come a long way since 2017. Our AMR strategy started around that time, or just in 2016. And when I started at the foundation in 2017, was just on the heels of that Chatham House meeting that Ramanan mentioned. And at that point, the data in terms of what are the potential impacts of vaccines against antimicrobial resistant pathogens or antibiotic use was really poorly quantified, as he also alluded to. And so that really formed the basis of a lot of our strategy, which took the form of both funding the ARVAC consortium that Ramanan coordinated and led, and has generated data on a number of different pathogens that he also alluded to, as well as to the WHO, which I think has supported the development of their AMR action framework. So I think compared to 5 years ago, we have come quite a distance in generating some of that evidence. There are probably 2 or 3 things that I'll say in terms of priorities going forward. The first is, great that we have generated these data. We really need to figure out how to move these data into the realm of policy and into national action plans. I think there's still a divide between the vaccine world and the AMR world, and bringing those data, not just from great publications in Nature and PNAS and other high impact journals, but to the NITAGs, to the AMR action plans, is going to be a next step to actually realize the potential impact of vaccines in AMR. The second, and I think there are some data coming out on this, and both Ramanan and Matthias alluded to this, is decisions on vaccines are not going to be made, and decisions for national action plans are not going to be made solely in the Ministry of Health. They're not going to be made solely by the immunization division and the AMR division, who themselves need to speak to each other, but they're also going to be by the Ministry of Finance. And so ensuring that we actually have the cost effectiveness and cost impact of using vaccines as a lever for AMR, I think is going to be an important piece of evidence to really push forward. Related to that is a third thing. The third point I'd like to make, or actually I'll have 2 more points. The third point is that when we talk about vaccines impacting a specific pathogen, we also have to take a step back and realize that clinicians and practitioners are not encountering a specific pathogen, they're encountering syndromes. And so this is going to be a challenge when we're trying to think about the potential impact of vaccines on antibiotic use, particularly in low and middle income countries where diagnostic tools are perhaps used less or less available. And so antibiotics become a tool that is used to try to treat a syndrome. So reducing one specific cause of a syndrome may result in some reduction in antibiotic use, but we need to be able to figure out how to measure that, and how to measure that in the context of the larger syndrome. I want to allude finally to a question that was raised, I think, in the Q&A and in the chat, which was, there are, and I think Cal alluded to also, that in the Graham report, of the 6 top pathogens that are causing or attributed to cause AMR attributable deaths, vaccines are really only available currently for 2, strep pneumo and then BCG for tuberculosis. And I think there can be some significant progress even on TB. But the question was raised, how do we prioritize which vaccines to make and produce? It's a massive effort. You've also mentioned that this will take many years and a huge investment. And so I think we need to look at, where can we make the greatest impact in vaccine development for a specific pathogen, and how will that overall make that impact on both deaths due to AMR as well as antibiotic use. For the foundation, for example, that focus has really led to a prioritization of Klebsiella pneumoniae. We have a priority focus on neonatal sepsis, and Klebsiella, as data that we have supported to the generation of, has suggested causes or is in the causal chain of upwards of 40% of neonatal infectious deaths. And so an impact of Klebsiella vaccine, much of which is due to drug-resistant Klebsiella, could be significant both in that population and then even in higher income countries. So I think that thinking of that prioritization lens will be critical in the product development pipeline as well. So I'll stop there.
Thank you, Padmini. Before I come to you, Carolyn, I wanted just to follow up, unless, there you are, Padmini, you sort of moved slide. I'm a little bit, I'm not, and this is true for Cal too, and anybody, I'm not confused, but I'm of multiple minds about this issue of pathogen-specific versus syndromic-specific approaches. You raised this issue about, if you're only attacking one pathogen that is, then there are several that cause the same syndrome, what you're going to do. But I know that vaccine development traditionally has been very much pathogen specific. So I'm wondering, are we going to go, you know, we're going to look back in a few years and go, you know, this was a mistake. We had to think of, we should have thought of these vaccine approaches as we need to deal with this syndrome? Or do you think that, you know, for example, the Klebsiella story, what's your view on it?
So,
and then
so maybe
Carolyn, go ahead.
Should I go? Okay.
Yeah.
Yeah. So maybe I'll just talk in terms of the Klebsiella prioritization, for example. So neonatal sepsis in low and middle income countries, kind of consistently, the top 4 pathogens are Klebsiella, and then Klebsiella usually at the top, and then in some order, varying in different geographies, E. coli, Staph aureus, and Acinetobacter. But if we look consistently, the proportion that Klebsiella contributes is highest and really associated with significant mortality. And so that allows us to prioritize that. We believe that actually addressing that Klebsiella mortality should make an impact on neonatal mortality overall, and certainly neonatal infectious deaths. I think one of the things that I wanted to communicate in talking about the syndromes is not just choices and prioritizations of pathogens, but challenges in terms of measuring that impact of vaccines and thinking about how to measure that impact of vaccines on AMR and antibiotic use. And I know that the Wellcome Trust has put quite a bit of energy into funding this field. And I do think that thinking about, you know, when we think about, for example, the typhoid fever vaccine, which we know can make an impact on, and certainly the modeling data have shown can make an impact on both the incidence of typhoid fever as well as drug-resistant typhoid fever. But the presentation of fever overall is going to be a challenge to figure out how does this make an impact on antibiotic use in febrile illness overall. And I think that there's an effort that needs to be made to better help quantify that in low and middle income country context. I'm curious to hear what my other panelists think.
Carolyn, why don't you go ahead, then we'll come to Ramanan.
Great. Well, thanks very much, everybody. My name's Carolyn Deal. I'm with the National Institute of Allergy and Infectious Disease, part of the NIH in the United States, and I'm the branch chief for the enteric and sexually transmitted infections branch. And so one of the things that I think you saw from Lang Ling's presentation is NIAID really has taken a broad interest in how we approach the issues of antimicrobial resistance, both from looking at vaccine development. But one of the other things I wanted to bring up today that I think is another technical challenge and a research gap, and it goes to what you were just talking about, which is syndromes, which is the development of point-of-care diagnostics. Because one of the ways you look at how do you approach how you measure AMR in syndromes is developing better point-of-care diagnostics to move from syndromic management to etiologic diagnosis. And this has certainly been of large discussion, particularly within the STI infection management area, where you see a lot of potential maybe the not best approach to patient management when you're treating syndromes such as cervicitis, as opposed if you knew what the exact diagnosis was. So we're focusing a lot on vaccines in this, but I think another area for research gaps and challenges is point-of-care diagnostic development. But the other issue I think that is a real challenge as we look at all these prioritizations is many of the cost economy issues are based on mortality. And that leaves out some of the morbidity issues that are associated with many of the other infections. And so a challenge, I think, to the health economists is how you measure that in our value assessments is the issues of morbidity as opposed to just the economic impact of mortality. And lastly, just to go back to what Dame Sally said, I think one of the things we realize is the public health community and all of our partners in therapeutic development, I think we're all beginning to realize that we will not be able to develop new antibiotics fast enough to stay ahead of the resistance issues. And so that's, I think, one of the reasons that vaccines have become such a higher priority, and the reprioritization in some of the pathogens that we're looking at, focusing on vaccine development rather than antibiotic development for those. And a good example, as Dame Sally pointed out, is Neisseria gonorrhea. So I'll stop there and see what other people have to say. And thank you very much, Bill and WHO.
Thank you, Carolyn. I'll just add that I think not just can't develop them fast enough, but they don't necessarily last that long, right? That's
Exactly.
the story of antibiotics. Ramanan.
Thanks. So I'm sure Padmini meant to mention this as well, and I forgot to mention this in my talk, that the vaccine trials provide a great opportunity to collect evidence of the effect of vaccines on antibiotic consumption. So a paper that we published recently in the context of an RSV trial, even though the RSV vaccine was not successful, the trial information showed that it could have a significant effect on, and this is Novavax, could have a significant effect on antibiotic consumption. And I think that we need to now work with industry colleagues to systematically collect that kind of evidence going forward for all vaccine trials. I don't know if there's a mechanism by which this can be added on to all vaccine trials, but that would be helpful. The second is something that, that was just mentioned by Carolyn, which is this idea of, and also by Padmini, the idea of you're talking about syndromic, symptomatic drivers of antibiotic consumption. So you could have taken away a major cause of serious illness, but people may still take the antibiotics because they're just used to taking it for the symptom. They're not taking it for, an underlying disease. But that said, if we have widely used the vaccines that could take away the reasons for serious illness and mortality, we could then press a lot more on antimicrobial stewardship as a way of reducing antibiotic consumption. Now, that also involves the diagnostics piece, but it's a much more complex piece. But we can do that with much greater confidence. Today, it's hard to push to reduce antibiotic consumption because that antibiotic is probably and potentially saving someone's life. And so I think this is to say that vaccines really are quite important. We might not necessarily see automatically the effect of vaccines on the antibiotic consumption, but the vaccines allow us to try to push the antibiotic consumption down without, worrying about lack of access, killing off people. And I think this is an important, point to be made, that we shouldn't just look at consumption and resistance. It's a much more complex picture out there.
Yeah, I think and I want to give Cal a chance because you talked about vaccine development, Cal, and priorities there. But I do think that if we had a combination of vaccines against certain syndromes, it makes it much easier. If you had just to take the one that I'm most familiar with, the 3 major bacterial pathogens for otitis media, and you had pneumococcal, which you have, but you also had Haemophilus and you had Moraxella, non-typal Haemophilus. Then a child comes in with otitis, and you could presumptively not give them antibiotic because you know that if they're vaccinated against the 3 major pathogens. But I wanted to ask Cal, in the enteric space, how do you see that? Because typhoid vaccines are there, Shigella vaccines are coming, other salmonellas are coming. How do you view the syndromic story versus what each guys can do by themselves?
I mean, that's a wonderful place to end up. I think at the moment we have challenges of getting the pathogen-specific vaccines through. There was a push for a while, and that was supported by the Gates Foundation, to push forward a combined Shigella and ETEC vaccine together. And if you've got to push 2 vaccines forward in combination at the same time, and you've got to have clinical efficacy endpoints for both of those to be successful, then that potentially delays your time through. So what is, and you know this very well, you're a proponent of this, what's going to be important is planning forward. So what's coming through the pipeline and what are the potential for the combinations of those vaccines come through the pipeline? So as Shigella vaccines are moving through, can we then look to potentially combine that with typhoid? We've got typhoid, but we're aware that there's another other key salmonella diseases of global health significance, particularly invasive non-typhoidal salmonellosis in Africa. Can we bring those on? Now, in some instances with typhoid, that is now a licensed pre-qualified vaccine, and we've got great data about how that's working and how that's having an impact on AMR. That can potentially be used as a train to drive other vaccines against other serovars of salmonella through. But when we bring in another pathogen, we probably have to bring that in like Shigella on its own in the first instance, but then look at a combination vaccine. And if we can plan ahead and keep that big picture in mind, then that will hopefully reduce the time once we do have more of a multiplicity of vaccines to get combinations together.
Thank you, Cal. I think that we are running over time, as you know, and it's very clear this discussion could be given an hour. I mean, Matheus, next time, or whoever, because I think it's a very rich area and there's different perspectives. I think there was one question, Carolyn, I wanted you that I saw that Duncan asked about the Shigella vaccine availability data. So that's an easy one, right, for you to.
Yeah. So as everyone's aware, most of all of our vaccine trials were delayed because of COVID challenges at our sites. Probably looking at those trials moving forward now, late summer to fall. So at the end of probably next year or the year after. So I think we're catching up after COVID delays. But I would like to add on one thing, Bill, to Cal's comments just now, because certainly the idea of how we add on to existing vaccines with other vaccines is an important issue. And I think that's one of the things that early discussions with a lot of the regulatory agencies are going to be a key, because how we add on into an already existing vaccine for those combination vaccines is something that may be on a case-by-case basis, but there may be some general ways that we can think about doing that. So I'd just like to add on to Cal's comments about that, because that's also an area we're very interested in how we can move forward with that.
Yeah, and I do believe, as you know, that making the case that this is important,
yes,
that in, say, the antimicrobial resistance space, it is important to have
yes,
combinations, is key for regulators to engage creatively on this. So I think that's part of incumbent on all of us to make the case.
Yeah.
I want to thank all of you. I'm sorry we can't talk longer because we've got the next session of very interesting stuff. But thank you again for participating in this one. We were going to take a break, but I think we're not going to take a break by the chairman's prerogative, as much as I like breaks, and so we can move on to the second session. This one is dedicated to discussing how we actually move forward. How do we translate these research issues and questions and findings into action? And the first speaker on this second session is Isabel Frost, who's going to talk to us about the clinical pipeline of vaccines against WHO priority pathogens, sort of I think a continuation of what Matheus was discussing. Please go ahead, Isabel.
Hi everyone, and many thanks for the invitation to talk at the GVIRF. It's a pleasure to be speaking to you, and I'm looking forward to talking to you about the work we've been doing on the pipeline for vaccines against pathogens that have been prioritised due to antimicrobial resistance. So why did we formulate this pipeline? Well, you've already heard from Matheus about the broader work that we're doing at WHO on vaccines and their impact on antimicrobial resistance. And really it became clear that we needed to have this mapping and understanding of what vaccine tools might be available in the near future, in the further future, where there might be opportunities for development, and how we might produce a document that could help inform funders and developers the information that they might need making investment-based decisions. This, of course, builds on the yearly antibacterial agents in clinical development and the preclinical pipelines that are already produced by the AMR division at WHO. And this work was done in really close collaboration with Peter Bayer, Valeria Gigante, Hatim Sati, and also Pilar Garcia-Bello from the AMR division. Very brief overview of the methodology. We had an initial data collection phase where we went through internal WHO documents, we looked at clinical trials and did a systematic review of clinical trials, we went over industry repositories, and we also did a kind of desktop literature review of reviews that have been done in this area, and also looked at the grey literature that have been published, things like the Wellcome Trust report on vaccines and AMR and other reports that have been done in this area. We then got feedback from experts that we approached on that list and generated a finalised list of the different vaccine candidates that were in development, and these were also incorporated with feasibility assessments to create a final report which is about to be published. We've also submitted a journal article, and there will also be this data available to use interactively on the WHO Global Health Observatory, and we'll also be sharing this with the AMR R&D Hub. So I mentioned that we combined the data on the pipeline with indicators assessing feasibility. Looking at the pipeline, we realized it was really necessary to not just give this mapping of the pipeline, where one might think, okay, well, has development not happened there because there wasn't enough investment in that particular pathogen and development of vaccine candidates, or has it not happened because it's actually really challenging? So to kind of tease that out, we wanted to incorporate these assessments of feasibility in order to compare these different vaccines, for some of which there are already vaccines that are licensed and used, and for some of which, you know, there's not really anything even in the pipeline. To create comparisons between those different candidates, we needed to develop vaccine profiles. What might a vaccine look like against each of these different pathogens that we were looking at? So these profiles were based on 5 different assumptions: what might be the efficacy, what might be the coverage in the target group, what would be likely to be the duration of protection, what strain or disease might be prevented, and who would be in the target population. For existing vaccines, of course, this was simpler, and we thought more about what might be the feasibility of expanding coverage to meet WHO immunization targets. For non-existing vaccines, we tried to align where there were published product profiles. We also considered late-stage vaccine candidates, if those were there. We looked at the literature, we looked at modelling studies and research that had been done that might suggest what a vaccine would be likely to look like in order to have impact. And these were developed also, of course, in extensive consultation with experts on those specific pathogens. In some cases, there is more than one vaccine profile for a given pathogen, because the different vaccines that you might get against those pathogens, that pathogen looks significantly different. So thinking about something like extraintestinal pathogenic E. coli, maybe a vaccine against urinary tract infections, or maybe a vaccine against sepsis. So in those cases, we would have 2. Next, we needed to develop a series of indicators in order to assess feasibility. We worked very closely with PATH, London School of Hygiene and Tropical Medicine, and our own technical advisory group on vaccines and antimicrobial resistance in order to develop a set of indicators. I won't go into too much depth on these because there's not loads of time, but they broadly came under 3 categories. The first of these was biological feasibility. So where are current candidates in terms of clinical development? Are there candidates in clinical development? Are there licensed candidates? What might be our understanding of immunity? Is strain diversity likely to be an issue for vaccine development? In terms of product development feasibility, we thought about the availability of in vitro and animal models, whether or not human challenge models were available or necessary, and what might be the ease of clinical development. In terms of access and implementation feasibility, we thought about whether or not that vaccine might be implemented within existing delivery systems, what might be the commercial attractiveness of such a vaccine, was there already an established policy and licensure pathway, and what might be the acceptability and the ease of uptake for such a vaccine. So then we developed thresholds for each of these and went to experts in order to assess them. Now onto the results of the pipeline. The preclinical pipeline, first I should say, this is really, it's non-exhaustive. This is a kind of constantly changing space, so it's a snapshot of what we were able to find. We were very much focusing on candidates that were at the later stages of preclinical development and really about to go into clinical trials. We identified 94 active preclinical candidates that you can see on this graph. The graph, you can see the pathogens along the bottom and the number of vaccine candidates, the numbers are above each bar. The colours here show what their category is for that pathogen within the priority pathogen list, so whether it's critical, high or medium. Of all the pathogens that we considered, only Ephesium and Enterobacter species had nothing in preclinical development. And kind of harking back to my original point about this being a constantly changing space, we only found one mRNA candidate, though of course it's likely that there will be more of those in the future. In terms of the clinical pipeline, we identified 61 vaccines that were in active clinical development. And here, when I say active, I mean we identified some form of activity within the last 3 years, or they were still listed in their company portfolio, or when we went to experts, they were able to resolve for us whether it was active or activity was no longer being continued on that particular candidate. There were no candidates in clinical development against Ephesium, Helicobacter pylori, Pseudomonas aeruginosa, Acinetobacter baumannii, Enterobacter species, or Campylobacter species. And this graph is very similar to the previous graph, and again color-coded by those categories within the bacterial priority pathogen list. This graph now goes into a little bit more depth on that clinical pipeline and the data that we gathered there, because we also included vaccine candidates that have become inactive or discontinued over the last 10 years. So this gives a kind of broader view of the clinical and preclinical pipeline and where investment has been going on. You can see that each of these sections is an individual pathogen, and then the kind of phase of development is shown from 1 to 3 along the bottom, and we have coloured these candidates by their activity status. So if they're active, then they're in purple, and those that are inactive are in green. You can see that Streptococcus pneumoniae is closely followed by TB in terms of having the most vaccine candidates in phase 2 or in phase 3. There are also candidates in phase 3 for gonorrhea, paratyphoid, and Clostridioides difficile. The pathogens that had the highest number of candidates in phase 1 were ETEC, so enterotoxigenic E. coli, S. pneumoniae, and Shigella. There are some pathogens which don't have active candidates currently, but that's not to say there hasn't been previous investment, and they have various failed candidates. So there has been investment that's been happening, it's just that they weren't successful candidates, and that's for Campylobacter, Helicobacter pylori, Pseudomonas aeruginosa. And it's also probably worth mentioning that there are some of these pathogens which have had candidates which have got to really late stages of development and then failed, of course, at really high cost. So those are Staphylococcus aureus, C. difficile, Streptococcus pneumoniae, Hib, Haemophilus influenzae type B, and ETEC. So we combined the results from the feasibility analysis and the pipeline overview in order to go through each of the pathogens on the priority pathogen list, in addition to TB and C. difficile, and categorize them in these 4 different categories. The first of these categories is pathogens that have vaccines which are already licensed. So those are pneumococcal conjugate vaccines against Streptococcus pneumoniae, Hib vaccines, Haemophilus influenzae type B, typhoid conjugate vaccines, and also tuberculosis, which of course has BCG vaccines. Our recommendations here were to expand use, even though there's a highly effective vaccine against Streptococcus pneumoniae. It was associated with 122,000 deaths due to drug-resistant strains in 2019, according to those recent IHME estimates that came out earlier this year. The other recommendation here is, of course, that the BCG vaccine is not as effective against the adolescent pulmonary forms of TB that are a really high burden at this point. So it's really important that we accelerate more effective TB vaccine development. The next category was pathogens with vaccines in late-stage clinical trials with high development feasibility. So these were gonorrhea, extraintestinal pathogenic E. coli, paratyphoid, and Clostridioides difficile. So for these candidates, for these pathogens, there are candidates in late stages of clinical development. These vaccines may be available in the kind of short to medium term future, and our recommendation here is to accelerate development where possible. The next category was pathogens with vaccine candidates either in early clinical trials or with moderate to high feasibility of vaccine development as assessed by our expert consultations. These are enterotoxigenic E. coli, Shigella, Klebsiella, Campylobacter, and non-typhoidal Salmonella. So for these targets, vaccines may be available in the longer term. Our recommendation is to continue development, but to also expand the knowledge around the potential for vaccine impact and to consider other tools, because it will take time, even if there were to be vaccines successfully developed against these pathogens. The final category is pathogens that have a small number or no vaccine candidates in the pipeline and have low vaccine development feasibility, at least in the near future. And these are Acinetobacter baumannii, Helicobacter pylori, Pseudomonas aeruginosa, Staphylococcus aureus, Enterococcus faecium, and Enterobacter species. Vaccines are unlikely to be available in the short to medium term, and our recommendation here is to really focus on other tools, including infection prevention control and developing safe and effective treatments against these infections. And I just have put in one slide here to discuss challenges for vaccine development against hospital-acquired infections. And that's because many of the pathogens that are associated with really high levels of antimicrobial resistance and are a kind of top priority on the bacterial priority pathogen list also cause hospital-acquired infections. So things like Acinetobacter baumannii, Klebsiella, Pseudomonas aeruginosa, Staphylococcus aureus, etc. You can see a list at the top of this slide. So some of the challenges that are associated with these and that kind of these different pathogens to some extent have in common are that because of the relatively low incidence of these infections in the populations that we are able to identify as target populations at present, there is a need for very large and therefore very expensive efficacy trials that take a while to conduct. The populations that are targeted or are likely to be targeted by such a vaccine are often very, very ill populations. They have multiple comorbidities, tend to have severely compromised immune systems, and that makes clinical endpoints very difficult to establish. Often the identification of those individuals that are at risk for hospital-acquired infections is at the point of ICU admission, and that means, of course, that the time between when they're being identified and potentially vaccinatable to the time when they might experience challenge with the pathogen that you're trying to vaccinate against is fairly short. There's not lots of time to have an effective immune response, and these are individuals that are very immunocompromised anyway, particularly at this point often. Finally, at present, there's no regulatory or policy precedent for a vaccine against hospital-acquired infections, which is not a complete barrier, but is somewhat of a hurdle that would need to be overcome. It's possible in terms of solutions to these. We've had a bit of a brainstorm. Potentially we could identify high-risk patients in advance, people undergoing elective surgery or hospital treatment. There's also potential on the licensure pathway that correlates of protection might be used in phase 3 trials, but really currently for all of the pathogens listed at the top of this slide, there are no correlates of protection at present. So a few final conclusions. Of course, vaccines are not the solution for every form of antimicrobial resistance, but vaccine development is absolutely possible for some of these targets and has a really high potential for impact. That said, vaccine development is challenging, failure rates are high, they tend to be very expensive, trials are long and require the recruitment of many different patients, and even that there are licensure processes, the process to licensure and the scale up of manufacture are also likely to take time. It's also worth a final note saying that 3 of the pathogens on the priority pathogen list have highly effective vaccines already, and yet there continues to be an AMR burden associated with these pathogens that could be even better targeted with these vaccines. Often access to vaccines is low in the places that have the highest burden of disease, and antibiotics are needed in these areas in order to manage that high burden of disease. However, of course, that further selects for resistance, and those resistant pathogens can then travel anywhere else in the world. So thank you so much for listening. I hope that you enjoy the rest of the GVIRF.
Thank you, Isabel. Sorry you got cut off so abruptly. That's our next presentation will be from Anand Balachandran from WHO, who's going to talk about, take this a step further. We can talk at this global level, that's which I guess we're at the moment, about the importance of vaccines here, but how do countries actually perceive vaccines as tools in fighting AMR?
Good morning and good afternoon, colleagues. I'm happy to make a short presentation on the role of vaccines in national action plans on addressing antimicrobial resistance. Now, as you know, the Global Action Plan on Antimicrobial Resistance was adopted in 2015, and it provided a blueprint for countries to develop their national action plans. And it had 5 strategic objectives, including improving awareness and understanding, strengthening evidence, basically through surveillance and research. Thirdly, to reduce the incidence of infection. And fourthly, to optimize the use of antimicrobial medicines. And fifthly, to develop an economic case and to invest in research and development for new vaccines, diagnostic tools, and medicines. Now, it should be noted that with regards to immunization, there are 3 clear areas where we feel that the immunization programs in countries can support the AMR agenda, particularly in improving awareness and understanding, of course, in reducing the incidence of infection, and also investing in novel vaccines. To give you a summary of the progress achieved since 2015, right now there are about 157 countries and territories that have established national action plans to address AMR. And the graph really shows the progress achieved over the past 5 years. And the data comes from an annual country self-assessment survey that WHO, along with our partners FAO and the World Organization for Animal Health and UNEP, have jointly administered over the past 5 years. And the data shows that the vast majority of countries are at levels where we feel that they have the capacity, they have developed their plans, they have the capacity, but still implementation is still not where it needs to be after 5 years. And those are the dark green bars that you see. So there is room for improvement and for additional progress. And also, funding is very limited for most of these national action plans, and only roughly about 32 countries have even funded their national action plans effectively. So where does immunization fall in terms of the national action plans? Most of these plans are quite ambitious, and they have hundreds of activities. And again, data from our annual country self-assessment surveys show that only in 26% of the countries there is a direct linkage between the AMR action plan and the national immunization program or the national immunization strategies. So there is significant room for building greater collaboration between the immunization programs and the AMR response at the country level. Now, the Global Action Plan on addressing AMR mandated the partnerships, meaning WHO, FAO, the World Organization for Animal Health, and UNEP, to come up with a monitoring and evaluation framework to monitor progress in the Global Action Plan. And here, I'm happy to note that there was a very clear intent to include specific indicators on immunization coverage. And these fall under an outcome focused on reducing the incidence of infections at communities, at the community level, but also healthcare facility levels. And in terms of immunization coverage, the focus was on at least 4 key antigens, the pneumococcal conjugate vaccine, rotavirus vaccine, measles-containing vaccine either alone or in measles rubella or measles mumps rubella combinations, and lastly, the HIP vaccine type B. So these were included as clear outcome indicators as part of the global monitoring and evaluation framework, and countries were really encouraged to include these indicators as part of their national action plan. In addition, I would say that if countries wanted to move further than these basic indicators, there are some additional indicators included in the Global Action Plan monitoring framework, and these include immunization coverage for typhoid and influenza, as well as using the SDG indicator 3B1, which is about the percentage of target population covered by all vaccines included in the national program. So right at the beginning of the establishment of the Global Action Plan on addressing AMR, immunization was included as a clear priority. Just to give you a sense of a situation in a country where vaccines played a critical role in addressing resistance. And this is an example from Pakistan on responding to the XDR typhoid outbreak. The situation was that in 2016, the first case was identified, which was resistant to fluoroquinolones and third-generation cephalosporin. And the country took some actions, both short-term and long-term actions, including campaigns, vaccination campaigns, and also including the typhoid conjugate vaccine into their routine programs. They managed to receive funding from Gavi to support this effort, and also they wanted to improve their WASH infrastructure and surveillance infrastructure. They also understood that this cannot be a standalone initiative and worked on integrating this effort with other areas, including improving WASH and IPC, strengthening clinical diagnosis, collection of data, treatment guidelines, etc. And what was most fulfilling to see was that the predicted impact of the typhoid vaccine. And studies showed that 1.2 million typhoid cases would be averted over the next 10 years. And also close to 900,000 XDR typhoid cases would be averted over 10 years based on the inclusion of TCV in the routine program in Pakistan. So this really highlights the impact of vaccines and its impact on resistance. Some next steps, what is WHO doing to further strengthen the inclusion of immunization programs into the overall AMR response? So currently the focus with regards to the AMR response has primarily been the focus on either the bugs or the drugs. And in fact, people and patients are rarely mentioned in the Global Action Plan. And diagnostics is also very rarely mentioned in the Global Action Plan. These are some big gaps. So as countries plan to develop their National Action Plan 2.0, WHO is preparing a people-centered framework for addressing AMR, which will take a more programmatic and a comprehensive approach where we want to identify sets of interventions that are interdependent and that are country specific and context specific, that really promote the engagement of the community and addresses inequities in access to health services and medicines and diagnostics, etc. And it really promotes the linkage between addressing AMR and broader health systems strategies like universal health coverage, primary health care, and more recently, the pandemic preparedness planning efforts in countries, because we have seen the impact of COVID-19 response measures and the impact on resistance to various antimicrobials increasing, particularly in ICU settings. Lastly, we wanted to create this framework so that it provides a face and a voice for AMR, which is currently lacking. And this is very important for policymakers and decision makers who have to make political decisions and manage various other priorities. So this people-centered framework includes 4 key pillars, starting with prevention of infections, secondly, access to essential health services, thirdly, timely and accurate diagnosis, and fourth, appropriate and quality assured treatment. So these 4 pillars are analyzed across the community level, the primary care level, and the healthcare facility level. And this is a simple model where we are going to look at what are the challenges a patient or people face in these 4 pillars, and also what are the health systems challenges with regards to provision of quality care and quality services for prevention, access to treatment, access to diagnosis, etc. So in this model, we have ensured that immunization will have a key role. For example, in the pillar on prevention of infections, at the community level, based on guidance from internal working groups, weak immunization programs, and at the health systems level and vaccine hesitancy at the people or patient level were considered as some challenges. And there were some specific interventions then proposed to address these challenges, including how do you expand the use of licensed vaccines so that the routine national immunization programs include the vaccines that were mentioned earlier as part of our indicators. And similarly, how do you use community organizations and others to raise awareness at the community level that immunization has an impact also on reducing antimicrobial resistance? Similarly, at the national level, one of the challenges is about the governance mechanisms on AMR, and the second challenge in many countries is the availability or lack of availability of certain vaccines. So here some of the interventions could be how to ensure greater linkages between the AMR action plan and the national immunization programs at the national level, but also at the subnational level. And in terms of the availability issues, how do you strengthen supply chain of essential vaccines? How do you invest in more research and development for novel vaccines to prevent infections, especially infections that then lead to greater burden of antimicrobial resistance? And lastly, the important research being done already in terms of the impact and the value of vaccines on addressing AMR. So this is a very quick snapshot of what might come out of this people-centered framework, where we identify specific challenges and then we identify specific interventions, and countries could then decide a narrow set of interventions or a package of interventions that can address these challenges. So in summary, I would like to say that the role of vaccines against AMR is still not very well understood at the country level. It is included in national action plans, but in terms of the linkage between AMR and the national immunization programs, I think a lot more can be done. And getting the message that preventing infections and chronic carriage will reduce the use of antimicrobials and reduce the selection pressure on AMR, I think this core message should be shared and more widely disseminated amongst the healthcare professionals in countries. Secondly, I would say we need to do more to ensure that the AMR national action plans, where there is more prioritization to be done, that there is specific linkages with the national immunization programs, and these are also costed so that a country knows what is the cost of implementing an overall national action plan. That includes vaccination as a key component. In terms of other short-term responses, vaccines have shown to really help bridge the gap in countries where there is very poor wash infrastructure, water, sanitation and hygiene infrastructure, and also infection prevention and control, national guidelines and infrastructure in healthcare facilities. So vaccines can be used as a short-term bridge to reduce infections. In the long term, we feel that essential vaccines, particularly those that were mentioned earlier, are really essential to prevent and control AMR, and these need to be incorporated into the immunization programs. Lastly, as we develop a new national action plan guidance for version 2.0, the WHO people-centered framework, we would really call upon the immunization community to support this effort and to also ensure that vaccination programs are prioritized as countries develop their AMR national action plans or revise their national action plans or cost their national action plans. Immunization needs to be firmly embedded in this people-centered framework, and it could focus on raising awareness. It could focus on regulations, supply chain, and also ensuring that immunization has a short-term function, but also some long-term functions in terms of reducing AMR. Thank you so much for your attention.
Thank you very much, Anand, for that excellent presentation. I think the issue about the role of vaccines against AMR not being well understood is most cogently portrayed, or at least that when it is understood, when you look at the example of Pakistan, as you showed and we've talked about, and now we're going to hear about the example of Zimbabwe, where vaccines have been used as tools to combat AMR.
Good morning, good afternoon, good evening, wherever you're connecting from. It's a pleasure to be invited to this conference with a theme, vaccines as tools to prevent AMR, advances, challenges, in the future. Today, I'm going to share with you how Zimbabwe government have used vaccines to control the outbreaks which were caused by resistant organisms. My name is Tapmane Mashe. Just to start my presentation, I'm just going to give you the introduction, which is going to cover the National Action Plan on Antimicrobial Resistance. I'm going to share with you the 2 case studies on which the government used the vaccines to control the outbreaks which were caused by resistant organisms. Then lastly, I'm going to share with you lessons that we have learned from these 2 outbreaks, and also the use of vaccine in controlling AMR, and also share with you the way forward. To give you a background, Zimbabwe government undertook a situation analysis on AMR in 2015 to 2016. And during this process, where the government went out to gather data on the ground to check the extent of AMR in Zimbabwe, these are some of the points that was picked from this exercise. There is growing resistance to common infections such as HIV, TB, malaria, gonorrhea, and of some of the diarrheal diseases. And one of the major factor or the major driver which was picked to be associated with this increase in resistance was irrational use of antimicrobials in the human, plant, and animal sector. These 2 observations were the pillar observations for the development of the National Action Plan in Zimbabwe, which was launched in 2017. In this National Action Plan, one of the activities which was included was the search for alternatives to antimicrobials. And as the pillar groups, what was agreed upon was to add traditional medicine, probiotics, and vaccines as some of the alternatives to antimicrobials. For now, let me go straight to the 2 case studies to show you how the Zimbabwe government has used vaccines in outbreak response and also to control outbreaks caused by resistant organisms. So I'm going to discuss or to share with you 2 different outbreaks. One, the cholera outbreak. Secondly, the typhoid outbreak. But let me start with case study number 1, which is the cholera outbreak. In Zimbabwe, Zimbabwe has been recording cholera outbreaks since 1972, but in different years. So for this presentation, I'm just going to share with you 3 different outbreaks. One that happened in 2018, another one that happened in 2011, another one that happened in 2018. So I'll start with the 2008 outbreak, which was one of the big outbreaks that occurred in Zimbabwe. This outbreak started in 2 suburbs in Harare, Budiriro and Glenview, and the total number of cases which were recorded for this outbreak was more than 98,000, with about 4,200 deaths. This was one of the biggest outbreaks that happened in Zimbabwe. Then the second outbreak that I'm going to talk about is a cholera outbreak that happened between 2010, 2011, and in this outbreak, about 2,162 cases were recorded. And for management of these 2 cases, oral rehydration was used. But to reduce the bacterial load, ciprofloxacin was used as the drug of choice for these two outbreaks. Then after about 8 years, another outbreak happened in 2018. In this outbreak now, what was significant for this outbreak, as you can see from the pictorial, was that the strain that caused this outbreak was resistant to so many antibiotics. It was resistant to about 14 antibiotics, which includes the first-line antibiotics to manage cholera: ciprofloxacin, tetracycline, which is doxycycline, and other antibiotics which it was resistant to. Of surprise, this strain of cholera was also ESBO positive, though in the management of cholera, ceftriaxone is not used as the drug of choice. But to manage this outbreak, or to reduce the bacterial load during this outbreak, azithromycin was used. Then it gave the government of Zimbabwe some strength to introduce new measures to manage outbreaks. I'll share with you how it managed this outbreak. So some of the mitigation measures I've already discussed to say oral rehydration and antimicrobials were used. Above this, water and sanitation, hygiene was improved in affected suburbs. Waste management was improved. Then health education was promoted in the affected suburb so that the community should know how to manage a cholera patient at household level. But above all these strategies which were used, which seemed to be working and which had worked during that outbreak, what the Zimbabwe government ended up doing was to introduce vaccination as a mitigation measure. About 1.5 million people were vaccinated in 17 affected suburbs in Harare. And this vaccination program helped Zimbabwe to contain this outbreak. Okay, let me go to the second case study. This is now the typhoid outbreaks in Zimbabwe. I'll just give you the list of typhoid cases in Zimbabwe so that you understand. Typhoid started in Zimbabwe, or it was first recorded in Zimbabwe in 2009. And during this period, 2009, the mainstream or the main antibiotic which was used to manage patients suffering from typhoid was ciprofloxacin. And in terms of resistance, it was working well. It was still zero resistant to ciprofloxacin. Then in 2012, it was still zero resistant. Then in 2014, that's the way the government of Zimbabwe started to peak resistance in ciprofloxacin, in which it was still very low at 4.6%. Then it rose to 21% in 2016, which came as a surprise. Why such a jump from 4.6% to 21%? In 2017, it rose with one figure to 22%. Then in 2018, which was also the same year which the Zimbabwe government recorded the cholera outbreak, the strains which were picked because the typhoid outbreaks in one of the suburbs called Kwazana were 75% resistant to ciprofloxacin. Then this approach now, or these results, made Zimbabwe to think otherwise. How did it manage that typhoid outbreak? These were some of the mitigation measures which were employed by the government of Zimbabwe. Yes, antimicrobials were used, but they had to change from ciprofloxacin to resafin and also to azithromycin. Then water and sanitation issues were also improved to waste management, health education in affected suburbs, is similar to the typhoid outbreak. Another point, or another mitigation measure which was employed by the government of Zimbabwe, which was of interest, was introduction of TCV. This vaccine was introduced in 9 affected suburbs in Harare, and about 318 doses were given to people between 6 months and 12 months. What lessons did we learn from these two case studies or these two big outbreaks that happened in 2018? What the government of Zimbabwe learned from this outbreak was that typhoid and cholera vaccines has an impact or reduces the prevalence of resistant pathogens. That's point number one. Second point, which we also learned from this, was that if we use vaccines, it also reduces antimicrobial use. The third point which the government used, which the government learned from this exercise, is I've shared before that it has used so many approaches, including WASH, including use of antimicrobials, including health education, but what overall, and also the use of vaccines to manage this outbreak. But what the government learned at the end of the day was that there is no magic bullet to control outbreaks, and integrated approaches or integrated strategies are required to combat outbreaks, general outbreaks, and also outbreaks caused by resistant organisms. In summary, I can share that to reduce the global burden of AMR, infection control through appropriate sanitation and hygiene is very, very, very important. It's key. Rational use of antimicrobials in the treatment of infections is also very, very important. Reduction in the rapid use of antimicrobials in livestock, it's a very, very important step that needs to be followed. Then overall, it's also very, very important, and also it's another way to reduce the impact of AMR in the population is also to use vaccines. Going forward, what the government of Zimbabwe ended up doing, using these two case studies, checking the benefits, the government of Zimbabwe agreed to include TCV as part of routine vaccine in the immunization program. And last year, 2021, about 4 million people were vaccinated with TCV in Zimbabwe. Another step which the government of Zimbabwe took was also to do a cross-sectional study to really check the impact of typhoid vaccines in the communities that received the first dose and also the immunization dose by checking the following: the trends, antibiotic use trends before the typhoid vaccine was introduced and also after the typhoid vaccine was introduced. Secondly, it had agreed now to say they also need to check the genomic structure of the strains which were causing typhoid outbreaks before vaccination and the ones which are now causing, if there are any, typhoid outbreaks after vaccination, to check if there's any relationship between the two strains, the before and after intervention strains of typhoid. With this information, I would like to thank you, the organizers who have invited us to share the stories from the field. And also I would like to thank the government of Zimbabwe, Minister of Health and WHO for supporting this work.
Thank you very much for a very interesting story from the field, as you say. And I was very excited to see about the cross-sectional study that is being done to actually measure the impact, which is the topic of our panel discussion, which we will be joined by 6 or 7 distinguished panelists. And if we could have everybody put on their videos. So the purpose of this panel discussion is to take this a step further and say, how do we ensure that these vaccines that are being developed or already exist to prevent AMR, how do we ensure really that they're going to be used? And so there's sort of 2 specific questions I want to ask our panelists to think about, which they've been primed with. One of which is, how do you actually ensure that the value of vaccines against AMR is systematically considered when you're deciding which vaccines to develop, introduce? How do we make sure that that's taken into account? And the second is, how does one actually measure the impact? So you can pick one of those. You don't have to answer both. The one that's most interesting to you. How do we make sure that, for example, countries really take this into account? So maybe I'll start just in order here with David Kaslow. Please introduce yourself and your thoughts on this topics.
Sure. Thanks, Bill. David Kaslow, Chief Scientific Officer here at PATH. Maybe I'll just make two really quick points in the interest of time. And I think both of them are actually probably a minor footnote to what the major points that have already been made in this webinar. And the first is on assumptions, and the second is maybe on definitions. So first, it appears to me that a key assumption underlying all of the presentations and discussions today is that vaccines inherently have a much lower likelihood of driving resistance emergence than antibiotics do. I think that's what we're all, I think, assuming. And while that assumption may be true over the longer time period, I think you mentioned that, Bill, compared to antibiotics, which have a pretty short time period to driving emergence. I do think we have examples of vaccines for which emergence of escape from vaccine-induced immunity exists. And this is influenza, it's pneumococcus, hepatitis B. Actually, early on, we saw variants occur that appear not to be, it could escape vaccine protection, and then potentially Bordetella pertussis. And part of the reason why I think we need to monitor this key underlying assumption is, as we move away from the legacy vaccine platforms that are built on whole pathogens and move to the newer vaccine technologies that are hyper-focused on a single subunit immunogen, can we assume that we're not going to get emergence of some of these? And so I think we need to be really careful about that. I think we need to monitor it. And the second thing that I would say is I do think we need a bit more precision. I think you already mentioned this, Bill, in terms of what do we mean by the AMR value proposition, and what are we putting forward to say that these are actually having value. And I think on one hand, we have the overuse and misuse of first generation antibiotics. So let's use the case of penicillin and group A strep, right? And there, I think what's happening is the value proposition there is maybe dysbiosis and, costs of vaccine, of drugs that aren't really driving any value. On the other hand, I think what's really driving the AMR value proposition, or the major value proposition there, is bad bugs, no drugs. And I think how you value those, how you ensure the value of those look very different. And I am a little bit concerned that we're conflating those two, and we're using this term AMR just generally, and we may be over-promising on some of that value. So maybe I'll leave it at that, Bill.
Thank you, David. Can I turn to Ed? What do you think about either of these angles?
Good morning, Bill. My name is Ed Buurman. I'm an Alliance Director at CARB-X, focusing on vaccines and therapeutics. And CARB-X is at the start of the development pipeline, meaning the CARB-X remit covers antibacterials, diagnostics, and therapeutics, among which are vaccines. And it covers from, let's say, hit to lead up to and including first in human. But what these have in common is that for all projects that we sponsor, we want companies to commit to access and stewardship agreements. As to the vaccines, we want to make sure that our vaccine global disease cover vaccines globally. What that means is that at CARB-X, we have an effort ongoing that evaluates, isolates from all regions of the planet, including, and maybe with an emphasis on those from LMICs, to make sure that we cover disease in LMICs, and that includes also that AMR strains are protected from as well. And then finally, although it is early in the process, we do look at cost of goods. So we do ask companies to think about that. And I'll stop there.
Thank you. I'll turn to John now. What are your thoughts?
Thank you, and thanks everyone for having me. I'm here on behalf of the International Federation for Pharmaceutical Manufacturers and Associations, and I am with GSK during my day job. I'm responsible for our government relations work and advocacy and policy around AMR, among other things. So we've been working on this for a long time, and IFPMA actually has a working group dedicated to vaccines and AMR, including the policy and systemic challenges facing development of new products. I think as we saw earlier in the pipeline analysis, there actually is a robust pipeline of vaccines that are AMR relevant. And that's not even to mention viral vaccines and other broad population vaccines that we know have an impact on antimicrobial use and therefore can mitigate or prevent AMR. We've spent a lot of time in industry and with other stakeholders talking about the economic challenges facing antibiotics, but it doesn't mean that vaccines have a clear pathway to the marketplace either. And many of those challenges have been highlighted today, and appreciate a lot of the comments. So I'll keep it brief because I think a lot of the key points were mentioned. First, I think on the data collection, as we've mentioned, the modern adage, if you build it, they will come, does not apply here. We need to understand better the demand signals. And one of the ways to do that is to work with stakeholders, with governments, to reflect that value in policy, whether it be value assessment policy, regulatory policy, or more broadly at the political level with national action plans, as mentioned by Dr. Srikanthia earlier. But it's not just that mention, it's actually implementing it. So I think with that, we're going to need a lot better data. This has been mentioned multiple times, and perhaps I'll just reference a proposal from Dr. Laxmanarian earlier. Collecting data needs to be a multi-stakeholder endeavor, and I think it requires a lot of early dialogue to sit down and understand what that looks like. So let's take the advantage of, or the example of clinical trials. I think we all agree it would be nice to collect the data around antibiotic use and other antibiotic or AMR related impact during clinical trials, but exactly how do you do that? We know that the challenges will vary health system by health system, health setting by health setting. And if we collect it, what are we going to do with it? I think we need to agree on what are the expectations. Can we make that a clinically reportable outcome? Can we actually see that ultimately be reflected in the label? And to the point about value proposition, actually impact that value proposition and therefore the demand and uptake among countries. So I'll leave it there. Happy to answer any questions. Thanks.
Thank you, John. I think that's quite interesting. I think the more specific we get, I think that's a really good, interesting concept that can you get it in your label? You know, that's what companies want. And that's an incentive to be able to collect the data. Marta, can we turn to you? I know that Gavi has been thinking very heavily about AMR. What are your thoughts?
Thank you. So my name is Marta. I'm the head of policy here at Gavi, and we oversee the vaccine investment strategy. So yes, Gavi, as a major investor in vaccine procurement and delivery, is well placed to develop approaches to evaluate the value of vaccines, including the impact on AMR. And every 5 years, we run the vaccine investment strategy, which is the mechanism we use to identify new vaccines and immunization products that are most relevant to supported countries. And it's a mechanism whereby we're able to add new vaccines in the portfolio. And we've already started to recognize the importance of considering the impact on AMR as part of our evaluation framework. Back in 2018, when we last ran the VIS, we had an indicator on the impact of vaccination on AMR. And it was, it was the first time that we had this. We included this under our global health security parameter alongside more typically used factors, including health impact, value for money. But there was very limited evidence at the time. And so the approach that we used was on expert opinion. To be able to at least start and provide a foundation for other tools for AMR and data collection. And we gathered views from a number of experts with relevant AMR experience to weigh in. and apply 6 criteria, including mortality, morbidity, societal impact, inequity, and social inclusion, and antibiotic use prevention, and the sense of urgency related to AMR threat. And we map this against potential when we map this against potential new investments, the vaccines with the highest predicted impact on AMR that we were looking at the time included malaria, cholera, and multivalent meningitis. We did also recently approve the investment to support malaria vaccine, and that, working in close collaboration with Mateos and WHO, also included an analysis on AMR. And as we look to the future, the next vaccine investment strategy, which will be kicking off at the end of this year for potential decisions in 2024, we are very keen to include the new data and new analysis to help us have a more objective framework and to consider AMR more robustly in future decision making. So we're very excited to see more development in the field and more data collection to be able to support that decision making. Thank you.
Thank you, Marta. Yeah, I think this question of the incentive, what is the incentive to collect data on AMR impact? That's an incentive. It's part of the VIS. You want to get your vaccine uptake by Gavi, collect the data, help them. Sonali, I'd like to turn to you. What are your thoughts?
Thank you so much, Bill. And so, speaking about the value of vaccines against AMR being systematically considered when deciding which vaccine to develop and introduce, I'm going to give you 4 concrete examples from a perspective of policymaking and financing. I'm a clinical associate professor at the Department of Global Health, University of Washington, Seattle, and a member of WHO SAGE. So the 4 examples include the fact that, first, WHO has is currently developing vaccine value profiles for 19 pathogens to capture what is known about the value of vaccines, including against AMR. And these will be published later this year. So the objective of the profiles essentially is that they would help with advocacy and decision making across a range of stakeholders. And secondly, to compare what is known for the different pipeline vaccines against a range of pathogens. And this information then would be very useful for vaccine development and introduction when it's planned, and for advocacy and decision making for the vaccine. The second example is we've currently developed a WHO evidence consideration for vaccine policy, or ECVP framework, which aims to provide early information on the clinical trial and observational data or evidence that is anticipated to be needed for WHO global, regional, and country level policymaking, program decision, and program implementation. This would be for new vaccines for priority diseases. And of course, the ECVP should be available before the design of pivotal vaccine licensure trials, so that the information there could be incorporated in the trial designs and strategic vaccine development work planning. And one of the critical parameters in the framework that we've inserted is the potential impact on vaccination on antimicrobial resistance, so that vaccine developers can consider this early in the clinical development program. The third example, the independent SAGE recommendations are required for all vaccines seeking WHO policy recommendations. And the impact of vaccines on AMR is really important for the discussion for relevant vaccines. The fourth example, as Martha mentioned, the impact of vaccines on antimicrobial resistance is a key ranking criteria for Gavi's vaccine investment strategy. And that was one of the reasons why we had included it in the ECVP framework, to ensure alignment between the policy considerations and financing. And the other interesting thing now that we have now is that novel vaccine platforms like messenger RNA and hubs are being set up for messenger RNA vaccine technology transfer to scale up global manufacturing. This will essentially ensure that countries and regions will be able to identify their own priorities and to drive vaccine development, including for pathogens where AMR is a significant concern in their particular context. And then the vaccines could specifically target resistance determinants or resistance strains. And now we also have novel adjuvants, reverse vaccinology, structural vaccinology, bioconjugates, along with progress in antigen design that's come up, and a lot of this is thanks to COVID vaccines actually, which will be useful in the vaccines against AMR development. And we essentially will also need an integrated strategy of interventions to fight AMR. Monoclonal antibodies will be another key intervention along with vaccines. And monoclonal antibodies could probably play a key role in hospital-acquired infection to protect people at high risk, including the immunocompromised or elderly, because they would not mount an effective immune response to vaccines. And if there's an outbreak of nosocomial infection and insufficient time to mount an immune response to vaccines, then the monoclonal antibodies would come into play. So from our perspective of policy making and financing, the impact of vaccines on AMR is a key parameter. And we are fortunate now to have new vaccine technologies accessible in LMICs to drive vaccine development, and also interventions like monoclonal antibodies that will help in an integrated strategy along with vaccines against AMR. Thank you, Bill.
Thank you, Sonali. Our final panelist is Dr. Vinay Kumar from Bharat. I don't know if your video works, but at least your audio, I guess.
Yeah, thank you, William, for inviting me for this panel discussion. I'm Vinay Kumar from Bharat Biotech, India, and I'm part of this clinical research development department. And I'm part of this clinical development of several vaccines developed by Bharat Biotech. As Matthias mentioned before, that the vaccine, the diseases which are high burden, and we have developed this two major tools which address this antimicrobial resistance, rotavac virus vaccine as well as this typhoid TCV, typhoid conjugate vaccines. When it comes to your question that which vaccines we need to develop to address this antimicrobial resistance, I can think majority of us, we are focusing on to develop vaccines against non-treatable diseases, virus diseases, but we need to focus on mostly treatable diseases also, and vaccines against these bacterial infections to address this antimicrobial resistance. And we have developed such vaccines and supplying typhoid conjugate vaccines. And when it comes to the impact of these vaccines on this antimicrobial resistance, I would like to take that example of Pakistan's incidents. And recently, in 2016, there is an outbreak of this extreme drug-resistant Salmonella typhi. And we have supplied through Gavi to Pakistan to address this issue, our typhoid conjugate vaccines, typhoid TCV. And Aga Khan University from Pakistan has conducted a study to see the impact or effectiveness of this vaccine against this extreme drug-resistant Salmonella typhi. And they have showed that this vaccine has the 97% of effectiveness against this extreme drug-resistant Salmonella typhi. And as well as they have shown in the end of that 75% of the cases were reduced because of this vaccine campaign in the Pakistan. This directly shows that how important this vaccine's impact on this antimicrobial resistance. This does not reducing typhoid cases only, it also saves the lifespan of some antibiotics which are going to be the microbes develop resistance against them. So vaccines are important to address this antimicrobial resistance. They can save some of the antibiotics for future generations. Thank you.
Thank you very much for that. I think we may have time for one or two more comments. If anyone, now that we've gone around the panel, said, I heard something kind of interesting, I didn't think about that, or I can ask you a question. Does anybody have any additional comment that you wanted to make once you've heard other people's comments? It's all been said, I think. I guess that what I would like to ask is, whose responsibility is it to measure the impact of vaccines on AMR? It's the same question about measuring vaccine impact on disease. It's just an area that often we find that people are excited to do studies, clinical study efficacy, but when it comes to actually measuring the impact in a country, the donors run for the exits, the companies run for the exits. And I'm just wondering here, who's actually going to be doing this? I don't know who's funding, and maybe the representative from Zimbabwe could comment who actually is supporting the study, the cross-sectional study in Zimbabwe, the impact, but who should be measuring this? Whose responsibility is it? Because if we think it's important to show the impact, maybe Veena, you could answer, in Pakistan, did Bharat measure the impact, or was it the country? Who did it? And I guess Marta, you have that answer, and then we'll go to Sonali.
Thanks, Bill. So I mean, at Gavi, we really understand the importance of data collection to determine the impact on AMR for vaccine introductions, and we do provide financial support for disease burden surveillance and vaccine impact studies, including the WHO Invasive Bacterial Disease Surveillance Network. But lack of general disease burden data has really proven to be a historical bottleneck when considering new investments, including for those vaccines that could have a significant impact on AMR. So without that burden data, it's really challenging to justify inclusion of specific vaccines within shortlist for VAS. So I think it's a very pertinent question, and one that's really, really key for the introduction of new vaccines. Thank you.
Thank you. Sonali, what is your thought here?
So, Bill, like vaccine effectiveness studies are done, in countries and often, sponsored by the governments of the countries. Similarly, studies on looking at the impact on of new vaccines on AMR, should be prioritized by the different country governments. Essentially, they are funders, now looking at. They are willing now to fund this, and now we have, much better defined methodologies, including measuring antimicrobial use, measuring antimicrobial resistance, and measuring the antimicrobial resistome. We've got much more thought has gone into this, and more standardized methodologies available. So, they can get support from international organizations like WHO, but this is something that needs to be prioritized in different countries, because it's so important, considering the economic and health impacts in the country. Over.
David?
I'll just be very provocative and say, I think that this is just a perfect example of a global common good. Antimicrobial resistance, and this is not a private sector, private goods issue. And so if you take it from that lens, it's the public sector needs to step up and support this and to value the work around. So I think to try to push it to the private sector to own this, given the lack of incentives, given the market failures here, I think it's almost a no-brainer. But that's just being provocative. Over.
The perfect opening for you, John.
Well, I mean, I agree with that. I agree with what David said. I mean, as I mentioned earlier, I think this needs to be done in concert. So I think we can align incentives better for data collection on AMR, antibiotic use, and all of those things. We just need to agree on it ahead of time. We heard how complex and famously expensive clinical trials are, and this is doubly so for healthcare-acquired infections. This is just another cost that needs to be borne. And a commons way of approaching it, I think, makes sense. Of course, we've seen what happens with other commons problems, but I think together we can find a solution. The other thing I would say is if we get too hung up on more and more evidence, we're never going to act. I think we have a lot of good evidence that we've seen today that vaccines are good. They're valuable across a variety of health metrics. And so if we can take measures just to increase vaccination rates, for example, by building stronger adult immunization infrastructure in countries, that is going to go a long way to having a upside impact on the AMR front without having to collect more data. So it's something to consider. There's a lot of work we can do today without evidence.
Thank you very much, John. And thank you to all the panelists. I think that's a great way to end. We need data, but we shouldn't be paralyzed by waiting for the data. And I'd like to thank actually all the presenters. I'm going to turn it over to Peter Dull, who's a forward-looking individual, and we'll talk about the future here. Peter?
So I guess real quick, because we are at time, but I'm one of the co-conveners along with Lee and Martin of the GVIRF webinars. We are here to sort of, I guess, queue up the next one. So October-ish, we will be discussing correlates of protection, really leaning into what we learned around COVID and how we accelerated or did not accelerate product development through the identification and use of correlates of protection. We heard a ton about that during this last 3 hours around the need for correlates, not just obviously for COVID type vaccines, but when we're talking about these AMR focused vaccines, the non-typhoidal salmonellas, the acinetobacters, it's going to be kind of hard to do an efficacy study with these. So we're going to need to get smarter around that. So hopefully that'll be woven into the discussion in the October webinar. Stay tuned. Maybe it's not this group, but we will certainly invite everyone on this call as well as others to join us for what I think will be a really compelling and interesting and difficult discussion around risk benefit and access to correlates of protection. So Bill, that's what I got.
Did you say when it was, Peter?
I said October. I didn't give you a hard date, but I got October for you.
Okay, October. Okay, thank you. And I think the last thing we were going to do is have a couple minutes from Kate O'Brien to send us off on our way. Is that right? It's a recorded presentation, I think. Yeah.
Dear colleagues and organizers, I'm really pleased to be able to give some closing remarks here at the Global Vaccine Immunization Research Forum webinar. This is a meeting that has been really timely with its focus on antimicrobial resistance. And I'd really like to start off by thanking all the speakers for the great set of presentations and really rich and stimulating discussions over the course of the meeting. During this webinar, we've heard about the problem of AMR. It's a global threat. We knew that we knew and we still know that it's a global threat. And we've heard about the evolution of our knowledge on AMR over the past decade, including on how to prevent it. The Global Action Plan on AMR has been well covered during this webinar. And we focused on research highlights and the impact of Shigella, rotavirus, and other enteric viruses and pathogens and vaccines. And we've heard about the problem of resistant outbreaks of cholera and typhoid in Zimbabwe and the role of vaccines and other interventions to prevent these sorts of outbreaks. Overall, we've been hearing about the importance of the role of vaccines as an effective tool in preventing AMR, and we need to work with what we have. For vaccines that are in early stages of development, we really need to work on understanding their biology and their relevance. We also have to work on product development and access and implementation, as well as the feasibility of that implementation, and focus on other interventions to tackle AMR while those vaccines are being developed. But for vaccines that are in late stages of development, we need to prepare for their introduction, and we especially need to prepare so that we can actually measure their impact on AMR once they're in use. And we need to expand the use of licensed vaccines like pneumococcal conjugate vaccine and rotavirus vaccine, and introduce new vaccines like typhoid conjugate vaccine. So I'd like to thank the WHO staff, the Bill and Melinda Gates Foundation, and NIH for organizing this webinar. And I'd really like to invite you to attend the next webinar as well of the Global Vaccine and Immunization Research Forum. Thanks to all of you for allowing me to make these closing comments.
Thank you, everybody. See you in October.
Thank you.